So this is Dr. Amrit Goel, Dr. Ashwani Sadana. We are presenting the hall 2. I welcome all our chairpersons to the meeting. It is an academic bonanza, and we hope we'll gain from presentation by a postgraduate student and knowledge from our chairpersons. Dr. Atul Srivastava, sir, our honorary secretary, and please welcome. Dr. Ajay Bharti, sir, Dr. Ashish Kumar, Dr. Puneet Gupta. Is everybody present, sir? Moderators, Dr. Sanjay Chaturvedi, myself, Dr. Amrit Goel, and Dr. Brijesh Sharma.
Yeah, good evening. Good evening.
Good evening, sir. So, can we start the meeting, sir? We'll have a 6-minute presentation followed by a 2-minute discussion. Hello?
Yes, please. Thank you.
Yeah.
Yes, please. Thank you. Start.
Okay. Let us start the meeting. Just a minute.
Dr. Goel, there is an echo. Just check if you have the. You have to not unmute it. You have to just log out from the audio from the other device.
Muting myself as well.
Okay, go ahead. You can invite the candidate to start presentation. Dr. Goel, we cannot hear you.
Okay, so are we audible now?
Yes, audible and good, no echo. Go ahead.
Yeah, thank you, sir. Little glitches in the starting. So
No
I invite Dr. Yuvraj Vimal from KGMC to please present his topic. Dr. Yuvraj, please slide share the screen. Yes, sir. Sorry. But light पीछे की रंग कर दो सर के ऊपर की लाइट ये नहीं इधर वाली
Good evening, sir. Is my slide visible to everyone?
Dr. Yuvraj?
Yes, sir.
Your voice is getting very slow.
Good evening, sir. Am I audible now?
You are audible. Go ahead. Speak loud.
Thank you, sir. Thank you, sir.
Yes.
Good evening, Dr. Yuvraj Vimal, Junior Resident, Department of Orthopaedic Surgery, King George Medical University. The topic of my presentation is prevalence of vitamin D deficiency in orthopedic trauma patient, a cross-sectional survey from a tertiary trauma center. Introduction. Vitamin D is a fat-soluble vitamin which plays an important role in human physiology. Its deficiency is prevalent worldwide. This deficiency have multiple consequences which are still being explored, apart from well-known skeletal complications. The burden and morbidity of skeletal trauma adds to the persistent deficiency, and it may have a detrimental effect in the injured. This chart shows how vitamin D acts and activates in the body and how it acts on different organs to maintain calcium homeostasis. Now, few studies in selected population group seems to suggest that prevalence in India is much higher than what would be expected. It ranges from 50% to 94% in different studies. This study was done to find a prevalence of vitamin D deficiency in patients presenting with orthopedic trauma and to establish any correlation with various demographic parameters. Aims and objectives of this study was to evaluate the prevalence of vitamin D deficiency and to establish correlation with various demographic parameters of patients, mode and type of injuries. Materials and methods. This cross-sectional study was conducted in Department of Orthopedic Surgery, King George Medical University, Lucknow. Source population was patients admitted in trauma center with an orthopedic injury. Sample size was calculated to be 124. Inclusion criteria. Age group of patients more than 18 years and patients admitted in trauma center, Department of Orthopedic Surgery, KGMU. Exclusion criteria. Age less than 18 years and patient on prior supplementation of vitamin D. We chose to exclude older patients with more than 70 years of age. Methodology. All patients admitted in Trauma Center, Department of Orthopedic Surgery, King George Medical University, Lucknow, who satisfy the inclusion criteria were assessed for 25 hydroxy vitamin D3 levels. This was checked on collected samples using electrochemiluminescence immune assay in our hospital clinical biochemistry laboratory. The criteria to classify patients is as follows: severely deficient less than 10 nanogram per ml, moderately deficient 11 to 20 nanogram per ml, insufficient 21 to 32 nanogram per ml, and adequate or normal more than 32 nanogram per ml. Demographic data including patient's name, age, sex, rural or urban background, religion, occupation, educational status, marital status, economic status, mode of injury, pattern of bone involvement, and type of fractures were noted. Economic status was classified according to modified BD Prasad classification. For the present study, fractures were classified as high velocity if they resulted from a fall from more than one story or high-speed motor vehicle collisions. Low velocity fractures were those resulting from assaults with a blunt weapon, closed fist, or falls from standing height. Rural and urban areas were defined as follows according to the Census of India 2021. Observation result. This table shows the distribution of cases according to age, according to sex of the patients, according to religion, according to occupation, according to different economic status, distribution of cases according to rural or urban background of the patients, distribution of cases according to educational level of the patient, and pattern of bone involvement and mode of injury. Now, in our study, we found that the prevalence of severe deficiency cases was 7.3%, while the prevalence of moderate deficiency cases was 36.3%. So, the overall prevalence of vitamin D deficiency was found to be 43.6%, which was very high. The proportion of vitamin D insufficient cases was 37.1%, while only 19.4% cases had normal vitamin D level. Association of vitamin D levels with economic status. Economic status shows significant association with vitamin D deficiency. P-value is 0.044. More proportion of deficiency was showed in socioeconomic scale of 5, followed by socioeconomic scale of 2. Association of vitamin D level with mode of injury. Mode of injury showed significant association with vitamin D deficiency. P-value is 0.037. Patients presented with fracture related to tribal trauma had more vitamin D deficiency. Association of vitamin D level with pattern of bone involvement. In our study, pattern of bone involvement showed significant association with vitamin D deficiency. P-value is 0.07. The severe deficiency was observed in cases of multiple hip and spine fractures. Now, age, sex of the patient, occupation of the patient, educational level of the patient, rural and urban background of the patients, and type of fracture did not show any significant association with vitamin D deficiency. In conclusion, we can conclude that the overall prevalence of vitamin D deficiency is very high. There is significant association of vitamin D deficiency with mode of injury, socioeconomic status, and pattern of bone involvement. Population-based program at national level must be developed to increase awareness of the problem at hand and to provide affordable vitamin D supplements, and also to provide vitamin D fortified foods to the Indian population at large. Research in this field continued support, provide a comprehensive picture of the ongoing vitamin D problem, and also to study and monitor the effect of a partnership between government, healthcare system, industry, and consumers aimed at improving the vitamin D status of India. Routine evaluation of vitamin D levels in all trauma patients is not feasible in a developing country such as India. Regular supplementation with vitamin D therapy can provide a favorable outcome in trauma patients. Thank you.
Thank you for your presentation, Dr. Yuvraj.
Thank you.
And you finished it well in time. So I urge our chairperson, Dr. Atul Srivastava, sir, Dr. Ajay Bharti, Ashish Kumar, sir, Puneet Gupta, please ask relevant questions. Sir.
So, Yuvraj, is this your first presentation?
Yes, sir.
Congratulations, very well presented. Go ahead.
Thank you, sir. Thank you, sir.
Do we have any more questions? Am I audible?
Yes.
Okay, so if we have no more questions, I ask the next candidate, Dr. Rajneesh Kumar, to please start the presentation. Thank you, Yuvraj.
Thank you, sir. Thank you so much.
Hello, good evening, sir.
Yeah, please slide share.
Hello, everyone. My name is Anish Kumar. I am third year junior student in Department of Orthopedic Surgery in King George Medical University, Lucknow. My today presentation topic is modified Baumann angle, a comparative study between dominant and non-dominant limb in pediatric age group. Introduction. The human elbow joint is a hinge type of synovial joint made up of three bones: proximal part of humerus, proximal part of ulna, and distal part of radius humerus, and proximal part of ulna and radius. The end of each bone covered with cartilage. Overall, 65 to 75% of all fracture in children occur in upper extremity, with supracondylar fracture of humerus accounting 60% among them. To understand injuries in pediatric elbow and to assess the degree of reduction after manipulation, various radiological criteria are used. These are modified Baumann angle in anterior posterior view, humeral condylar angle, anterior humeral line, and radial capitular line in lateral view. Dr. Ernst Baumann, while treating displaced supracondylar humeral fracture in children with close reduction and olecranon overhead traction, demonstrated that Baumann angle is an useful indicator of the adequacy of the reduction of the displaced supracondylar humeral fracture. Modified Baumann angle is measured on AP radiograph of the elbow between the long axis of humerus and the growth plate of the lateral condyle of the humerus and a perpendicular line along the shaft of humerus. It is commonly used as an outcome measure for supracondylar fracture of humerus in children. An increase in Baumann angle in supracondylar fracture indicates medial tilting of the distal fragment. However, there is a limited information about reliability of this measurement. It is used for evaluations of the displacement of pediatric supracondylar humeral fracture. It is measured during intraoperatively and postoperatively to evaluate the outcomes of surgery. A value of modified Baumann angle between 9 to 26 degrees is considered as normal. But due to significant variations in individual, it should be always compared to contralateral side, and a difference of more than 5 degrees is considered as abnormal. Since anthropometric parameters of Caucasians are different from European and Mongoloids, this parameter cannot apply on our population. Hence, there is need to characterize the anthropometric parameters of elbow among the children in the Indian population. A recent study showed that there was no significant difference in the mean Baumann angle comparing left to right side. Study done on Chinese children reports a negative correlation between Baumann angle and clinical carrying angle. Aims and objective: to measure the modified Baumann angle in pediatric age group, to compare the modified Baumann angle between both upper limbs in pediatric population, to study the effect of age, sex, handedness, and carrying angle on modified Baumann angle. Material and methods: this was a cross-sectional study of 1 year duration. Sample size were 113. Institutional ethical clearance and written informed consent were taken. Inclusion criteria: children in the age group 3 to 16 years who visited in the OPD and admitted in the Department of Orthopedic Surgery volunteer for the study, or those who are attending hospitals for some other cause. Exclusion criteria: history of tumor, trauma, bone or joint infection, surgery and wounds to any of the upper extremities, post-polio residual paralysis, metabolic bone disease like rickets and osteomalacia, neurological conditions with abnormal muscle tone like cerebral palsy, head injury and motor neuron disease, arthritis like rheumatoid arthritis, congenital orthopedic deformity, children who had not developed hand preferences at the time of study. Measurement of Baumann angle. Modified Baumann angle. Modified Baumann angle was measured on a true AP view of X-ray of elbow. The straight line was drawn through the middle of the humeral shaft by taking 2 central points on the humeral shaft, and second line was drawn perpendicular to the humeral shaft. A third line was drawn along the lateral condyle or growth plate. The angle between first and third line was gave the Baumann angle, and the angle between the second and third line gives us modified Baumann angle. Clinical measurement of carrying angle: with elbow in full flexion and forearm in full supination, the angle between the central axis of forearm and arm was measured using manual goniometers. Radiological measurement of carrying angle: it was measured on a true AP view of X-ray of the elbow by measuring the angle between longitudinal axis of humeral shaft and a longitudinal line drawn along the shaft of ulna. The axis of humerus and ulna were determined by 2 central points on the shaft of the respective bone. Observations and results: this table shows comparisons of linear measurement and modified Baumann angle between dominant and non-dominant sides in entire study population. There was a significant difference in the modified Baumann angle between dominant and non-dominant side. This table compares linear measurement and modified Baumann angle between males and female, and there was no significant difference found between male and female in Baumann angle. This table shows correlations of modified Baumann angle with different linear and angular measurement, and the modified Baumann angle showed weak and significant correlation with carrying angle, arm length, forearm length, and intercondylar distance. Conclusion: the study is an effort to evaluate the factor affecting modified angle, and the recorded measurement might be useful in managing elbow disorders and in reconstruction following trauma. The mean modified Baumann angle on the dominant side and non-dominant side were reported, and we found a significant difference in the modified Baumann angle between dominant and non-dominant sides. The mean modified Baumann angle in male and female were reported, and there was no significant difference found in modified Baumann angle between boys and girls. The modified Baumann angle did not show any trend with increasing age in our study. The modified Baumann angle So weak negative and significant correlation with carrying angle, arm length, forearm length, and interepicondylar distance. We didn't find any significant difference between clinical and radiological carrying angle in this study. Those having secondary sexual characters have lower mean value of modified Baumann angle as compared to those not having secondary sexual character in this study, and this difference is statistically significant. Thank you, sir.
Thank you. Thank you for sticking to the time limit. As a respect for the other participants, I urge Dr. Yuvraj and Dr. Rajneesh to stay in the chat room till all the participants have completed their presentation. And it would be great if all of us can open their videos so we can see each other. Now, it's an excellent presentation, Dr. Rajneesh. And do we have any questions? Any questions from the floor? I will meanwhile ask Dr. Kamaruddin to start his screen sharing.
Okay, sir. Good evening, sir.
Do we have any questions for Dr. Rajneesh Kumar? If we do not have, then we'll start with the next presentation. Dr. Kamaruddin, welcome.
Good evening, sir.
Yeah, please start.
Good evening, sir. Myself, Dr. Kamaruddin Khan. I am a secondary DNB resident in GMC, Mewat, Haryana. My topic for presentation is functional and radiological outcomes of metacarpal shaft fractures with mini fragment plate osteosynthesis. This study is conducted in Department of Orthopaedics, Government Medical College, Mewat, Haryana, and my co-author is Professor Siddharth Goel, sir. Introduction. Fractures of the metacarpals and phalanges are the most common fractures of the upper extremity. Too often, metacarpal fractures are treated as minor injuries and major disability results as stated by Lipscomb. Despite the numerous treatment options, Swanson aptly stated hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. Operative fixation of the metacarpal fractures has gained increasing popularity for the following reasons: improved material designs and instrumentation, better understanding of the biomechanical principles of internal fixation, demanding public expectations, good radiographic imaging, and better physiotherapies.
Dr. Gaurav, please stop your screen share. Dr. Gaurav?
My screen is visible?
Your screen is not visible. I think somebody else has shared his screen. I request that person to stop his screen share. Please, Dr. Kumar, please restart your...
So now my screen is visible.
Yeah, you can please switch to a bigger view.
Good evening, sir. It is visible.
Please
now.
use the full screen view, sir. In the right hand corner, you see the full screen view for the presentation. It's okay if you cannot find it, you can start it. Otherwise, you can start play.
I'm not able to find it.
Okay, start. Okay, you can continue. We will see. Please jump to your slide you were telling, and you can continue from there.
Sir, my topic of my presentation is functional and radiological outcomes of metacarpal shaft fractures with mini fragment plate osteosynthesis. This study was conducted in Department of Orthopaedics, Government Medical College, Mewat, Haryana, and my co-author is Professor Siddharth Goel. Introduction. Fractures of the metacarpal and phalanges are the most common fractures of the upper extremity. Too often, fractures of the fractures of the metacarpals and phalanges are the most common fractures of the upper extremity. Too often, metacarpal fractures are treated as minor injuries. And the major sir, I'm reading.
Next slide.
Just click on this. Just click on the slide on the left hand corner. It will come to the next slide.
Okay, sir.
And there's a button just above the left hand corner. Starts play PowerPoint. If you can see that.
Too often,
just
metacarpal
just above the left side.
No, sir, I'm not able to find it.
Okay, please just click on the slide on the left-hand panel, so it will change the slide.
Okay, sir.
Just click on the slide.
Despite the numerous treatment options, Swanson aptly stated hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. Operative fixation of the metacarpal fractures has gained increasing popularity for the following reasons: improved material designs and instrumentation, better understanding of the biomechanical principles of internal fixation, demanding public
Slides are not
expectation.
changing. Sorry to interrupt. Your slides are not changing.
Dr. Kumar, can you try to yeah. Yeah, just if you see the slide, there's a button on the top says from beginning. Just on the top of the first slide on the left side, there's a button says on from beginning. Yeah, just click it.
Okay, sir. So now it is okay?
1 second, let it play.
So now slides are changing.
I think there's some problem. You can just click on the slide on the number 4 or 5, whichever slide, so we can see it in the on the left hand panel. Can you just click on the slide? Yeah, now it is changing. Okay, please continue.
Okay, sir. So can I present this way? Because when I'm making it full screen, it is there is a problem. Hello.
Yeah, it is fine. It is fine. You present it this way. Just click on the left hand side so we can have the relevant slide coming up.
Okay, sir. Introduction. Fracture of the metacarpals and phalanges are the most common fracture of the upper extremity. Too often, metacarpal fractures are treated as minor injuries and major disability results as stated by Lipscomb. Despite the numerous treatment options, Swanson aptly stated that hand fractures can be complicated by deformity from no treatment, stiffness from over treatment, and both deformity and stiffness from poor treatment. Operative fixation of the metacarpal fractures has gained increasing popularity for the following reasons: improved material designs, better understanding of the biomechanical principle of internal fixation, demanding public expectation, good radiographic imaging, and better hand physiotherapies. Fracture healing in the hand is not the only goal, rather the functional outcome is of paramount importance. However, aggressive attempts at internal fixation may lead to soft tissue damage, tendon adhesions, infection, and the necessity for a secondary procedure for implant removal. Operative fixation must be used judiciously and with the expectation that the ultimate outcome will be as good as and optimally better than the outcome after non-operative management. Biomechanics of metacarpal fixation. The plate acts as a tension band. It is placed on the dorsal surface. Modern plates can withstand higher stresses, allowing for more active motion and early rehabilitation. 4 cortices of the locked fixation on either side of the fracture is equivalent to the 6 cortices non-locked fixation. Aims and objectives of the study are to assess the functional and radiological outcomes of metacarpal shaft fracture treated by mini fragment plating and to enumerate the complications of metacarpal shaft fractures treated by mini fragment plating. Material methods. This study was conducted in Department of Orthopaedics, Shahid Hasan Khan Mewati, Government Medical College, Mewat, Haryana. Including criteria.
Hello, please mute the other participant. Kindly mute yourself for the presentation. Request to other participant, please mute yourself. Dr. Kumar, please continue.
Inclusion criteria involves patients with a displaced metacarpal fracture, including compound grade 1, and patients with age from 80 to 60 years. Exclusion criteria: patients with fractures more than 3 weeks old, compound grade 2 and grade 3, patients with ipsilateral phalanx fracture, ipsilateral wrist fracture, and tendon injuries. Interarticular fractures of the metacarpals are also excluded from the study. Sample size: this study was conducted in 30 patients. It was a prospective study. 30 cases with diagnosis of displaced metacarpal fracture in the range of 18 to 60 years were taken. Materials used were mini fragment plate of 2.0 and 2.4 mm. And the surgical technique involves incision, that is a standard dorsal longitudinal incision, and extensor tendon was retracted. Reduction was held by an assistant with the help of clamp, and plate was applied over the fracture site. Mini fragment plate centered over the fracture side, and it is secured with or without compression by insertion of the mini screws on either side of the mini fragment plate. No patient was given post-operative support in form of splint or slab. Active and passive finger and wrist physiotherapy was started from second post-op day. Measurement of outcome. Patients were followed up at 4 weeks, 6 weeks, 12 weeks, and 24 weeks interval, and we used American Society for Surgery of Hand ASH total active flexion scoring system, which give results in the form of excellent, good, fair, and poor. Results. Functional outcome of the fracture At the end of the thesis, according to the ASH and TAF scoring system, in our study, we found 93.3% union rate in 28 out of 30 patients, with 63.3% having excellent result, 23.3% having good result, and 3.3% having fair, and 10% patients having poor results. Complication: out of 30 patients, 2 patients had non-union, 3 patients had stiffness, while 2 patients had superficial infection. Non-union was later treated on by bone grafting. Stiffness was later treated by aggressive physiotherapy, and superficial infection was later on treated by antibiotics and debridement. A few clinical photographs. This is the X-ray of a preoperative X-ray of a right hand showing fracture shaft of fifth metacarpal, AP lateral and oblique views. This is the preoperative clinical photograph showing swelling and deformity on the right hand side. This is the peroperative clinical photograph showing fracture and fixation with a mini fragment plate. And this is the post-operative day 1 radiograph of the right hand. And this is the clinical photograph at the 6-month follow-up with full functional range. Conclusion: thus we conclude that use of mini fragment plate is a good method of internal fixation in fractures of metacarpal. The stiff stable fixation given by plating withstand load without failure allows for early mobilization and satisfactory functional results. Limitation of the study were large multicentric studies required for meaningful conclusion to be drawn, and TAF scores were not calculated preoperatively. These are the references. Thank you, sir.
Thank you, Dr. Kumar, for the presentation. I would request you to please leave your video on and please be present for the entire meeting.
Sure.
I also request Dr. Yuvraj and Dr. Rajneesh and other postgraduates to please start their videos.
Yes,
Dr. Yuvraj, Dr. Rajneesh,
Yes, sir.
Dr. Modi, Dr. Gaurav, Manish Yadav, sir. So while we are having questions for Dr. Kumar, Dr. Manish Yadav, please set up your screen. Dr. Ajay Bharti, any questions for Dr. Kumar?
Yeah, this is Dr. Atul Srivastava. Can I ask a question to Dr. Kumar?
Yes, sir.
Yes, sir.
Kumar, 2 questions. One
Yes,
is that why did you exclude grade 2 and grade 3 injuries from your study?
So there are more chances of infection, and it can finally results will be not good in Kumar, because we will use plate and there is less subcutaneous tissue in the hand, and there are more chances of infection. And we usually use fixators in that case, mini fixators.
Okay, but as it is, the thing is open, you're going to debride it well, and then the thing is in front of you, you can fix it also as well. The second question to you is
Yes, sir.
that have you compared your study with intramedullary nailing versus plating?
No, sir. No, sir.
So you can go further and compare it with intramedullary nailing as well.
Sure, sir. Yes, sir.
Thank you. Nice
Thank you,
presentation.
sir. Thank you, sir.
Any more questions?
What were your physiotherapy protocols? How did you proceed for it? What were the cares taken to achieve maximal range of movements?
Sir, finger movements and hand movements were started from the second post-op day, and after 4 weeks and 6 weeks, we active physiotherapy was started for the patient.
Were there any specific steps to be followed?
No, sir, as per tolerated by the patient, as per pain.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Kumar, for the nice presentation.
Okay, there's
Thanks.
one. I want to have one question.
Yeah. Yes, sir.
You mentioned that you have few cases of non-union.
So 2 cases of
Could you?
non-union.
What was the cause for the metacarpal bone itself? It unites even if you treat it conservatively.
Yes, sir.
Was there something which led to the surgical intervention, which led to the non-union?
So we didn't follow it because we were having a short period of a study of around 9 months to 10 months only. So further data was not included in the study.
It's been reported that if you do not have the proper compression, even with the mini plates,
Yes, sir.
it leads to the incidence of non-union.
Yes, sir.
Okay.
Okay. So can we have the next speaker now? Dr. Manish Yadav. Are you ready, sir? Dr. Manish Yadav. You are not audible. Please unmute your mic. Dr. Manish Yadav.
Hello, good evening, sir.
Yeah, please start.
Sir, my slide is visible.
Your slides are visible. Please start.
Okay. Good evening, sir.
Please be on the time limit.
Yes, sir. Good evening, sir. Myself, Dr. Manish Yadav. I am here to present my paper that is functional outcome of pediatric femur shaft fractures managed with titanium elastic nails. Sir, coming to introduction, fracture shaft of femur along with subtrochanteric and supracondylar fracture, they represent about 1.6% of all bony injury in the children. And its treatment, it depends upon the age of the child, location, and type of the fracture. Management of these fractures have evolved gradually toward the operative approach. It's because of desire for more rapid recovery and with recognition that prolonged immobilization can have negative psychological effect on children. Management in children at 5 to 11 years of age is still a dilemma. Because presence of growing proximal and distal physis, they impose a challenge in the management of these fractures. Treatment option for children between the age group of 5 to 11 years, these include early spica, then traction, which is followed by the casting, then external fixation, plate fixation, and intramedullary nail. Popularity of flexible intramedullary nailing, its result from its safety, efficacy, and ease of implant removal. Then aims and objective. The aims of our study was to evaluate the functional and radiological outcome of titanium elastic nail in fracture shaft of femur in the children between the age group of 5 to 11 years. Then coming to material method, this study was conducted at Department of Orthopaedics in SHKM Government Medical College with a study population of 40 children between the age group of 5 to 11 year old. And we include children with fracture with Winkler's type 1 and short oblique or transverse fractures with Gustello-Anderson grade 1. Then exclusion criteria, we exclude patient with polytrauma with multiple fracture of same limb, then subtroch and supracondylar femur fracture, Winkler's type 2, 3, 4, open fracture more than Gustello-Anderson grade 2, then any pathological fractures. We include 40 patients, and it was a prospective study, and it was conducted over a period of 12 months, and we measure our outcome according to the Flynn's criteria, which include limb length discrepancy, malalignment, pain, and complication. This is a technique after clearance from the anesthesia department and PSC, the patient shifted inside OT and lying over the traction table after a spinal anesthesia. Then after proper painting, draping, and scrubbing, skin incision given some 2 centimeter above the distal physis, confirmed under the C-arm, an entry made with the help of awl, and some 2 centimeter proximal to the distal physis, and intramedullary TENS inserted and hammer inside the medullary canal until we reach the fracture site. Then we reduce the fracture under the C-arm, and we will hammer the nail advance in proximal fragment also. Then same procedure follow on the medial side. We'll make entry and then we'll advance the nail inside the canal. And so these are the pre-op X-ray. These are showing, and the post-op X-ray, the fracture fixed with the TENS, and these are the follow-up X-ray. So these are the clinical radiograph of the patient who can squat easily and who can stand, and there is no restriction at the range of motion at the hip and knee, and there is no limb length discrepancy. So functional outcome as per Flynn's criteria, we evaluate our patient on the 2nd week, 6th week, 3rd month, and 6th month. And after 6 months, out of 40 patients, we have 29 of cases who have excellent, and 9 patients who are successful, and only 2 patients who have a poor outcome. Then complication, so we have limb length discrepancy less than 5 mm in 2 patients, more than 5 mm in 1 patient. There was superficial surgical infection in 1 patient, and no patient in our study was recorded with delayed union, non-union. There was pertusion of nail in 2 patients, and there was varus malalignment in 3 patients, which was less than 10 degree. Conclusion, so TENS, it can be used successfully in transverse and short oblique fracture of the shaft of femur in pediatric age group between 5 to 11 years. Then advantages of the TENS, sir, it has shorter operative time, less blood loss, shorter hospital stay, and reasonable time of fracture healing, early mobilization, and there is a low complication rate. So these are the references. Thank you, sir.
Thank you, Dr. Manish, for a nice presentation. I'll now request our chairperson, Dr. Puneet, please ask questions to the candidate. Please unmute yourself.
Yeah. Have you considered the weight of the patients also besides the age?
No, sir.
because this the age, the weight of the patient is also important while we are taking the treatment option for the TENS.
Okay.
And the second thing is the you should measure the length. You should have the proper configuration of the TENS. You have to mold it according to the site of the fracture and then be done. So in the procedure, you must have described the exact method of TENS insertion.
Yes, sir.
Dr. Manish, why did you think there was bone lengthening in a few cases?
Sir, it's because of there can be at the time increased blood supply, sir, to the physis, which can lead to the limb deficiency. In case of injured limb, during the time of the healing, so the blood supply is increased compared to the normal side. So that.
Okay, thank
Dr.
you.
Amrit, can I have a question?
Yes, sir. Please go ahead.
Dr. Anoop Agarwal.
Yes, sir.
Wonderful paper, in fact. My only question is that what is new in this study? What I presume is that use of TENS nail in pediatric age group is an established fact for almost now more than a decade. So the study, the paperwork which you have done, what is new into it? Did you find anything new out of this study?
No, sir, nothing significant, anything we got.
Okay. So did you speculate anything new out of this study once you started studying this particular subject?
No, sir. Actually, we conduct these studies in the time of COVID. We were doing only emergency cases, sir. So we have to choose something.
See, my question is for all the PGs, that while you are conducting a study, what is the meaning of research? Research should not be taken by word that research means that you have to search something new by doing a search on the something which is already established. And if you're not doing anything new or not getting anything new, research. That's my thing. So purpose of presenting any paper in any of the forum is that either you're getting anything new out of that particular study, or you're trying to establish anything which is different from what is established. Thank you.
Thank you, sir, for your guidance. And do you have any other questions, or should I request the speaker to come up? So I request Dr. Modi to please start sharing your screen. Dr. Modi, can you hear us? Dr. Modi, are you there?
Yes, sir.
Yeah, please start your screen and start up.
Yes. Good evening, sir.
Yeah, please continue.
Sir, is my slide visible?
Visible. You are visible. Please continue.
Okay. Good evening, sir. Good evening to all. My study topic is comparison of a minimally invasive posterior approach and the standard posterior approach for total hip arthroplasty, a prospective and comparative study in a tertiary care hospital, Lucknow. First of all, introduction. A number of different so-called minimally invasive approaches are being used more and more for total hip arthroplasty. In principle, they can be divided into two groups, the muscle sparing approaches and the mini incision approaches. So in the former group, where muscles are not cut, includes the two incision technique, the anterolateral mini approach and the direct anterior mini approach. The mini incision group approaches involve a shorter incision in the skin, and less muscles are detached than in the corresponding standard approach. This group includes the mini incision lateral approach and the mini posterior approach. In general, the minimally invasive approach is described as having a lower degree of trauma for the soft tissues and in particular for the muscles. This opinion is based on the fact that the loss of blood is lower, rate of recovery is faster, the post-operative level of pain is lower and patients are released sooner from the hospital. It is not clear whether total hip arthroplasty performed via minimally invasive approach leads to a less muscle trauma compared to the standard approach. So the objectives to investigate whether a minimally invasive posterior approach for total hip arthroplasty results in lower levels of muscle-derived enzymes and better post-operative clinical results than those obtained with the standard posterolateral approach. Materials and methods, study design, a prospective and comparative study. Study duration from July 2021 to December 2021. Area where study conducted is Career Institute of Medical Sciences and Hospital, Lucknow. Inclusion criteria. Patients from casualty and orthopedic department who are ready to give consent and take participant in the study are included. And exclusion criteria. Patients with previous operations on the relevant hip joint and patients who are not able to comply with the standardized pain medication. Sampling procedure. 40 patients in total from orthopedic department and casualty in Career Institute of Medical Science Hospital, Lucknow district were included in this study by purposive sampling method. Two groups were compared in a prospective and comparative study, including 21 males and 19 females in total. The following parameters were examined: muscle-derived enzymes CPK, myoglobin preoperatively, and 24 and 48 hours post-operatively. Loss of blood, daily pain levels, the rate of recovery, that is time taken to attain predefined functional parameters. The Oxford hip score and the WOMAC score preoperatively and 6 weeks post-surgery, and followed by post-operative X-ray examination. Data collection and analysis. The statistical analysis is conducted using the computer program SPSS for Windows. For comparison between the two groups of surgical approach, the Mann-Whitney test was used in case of quantitative variables, and in case for nominal parameters, chi-square test was used. The level of significance was fixed at p less than 0.05. Institutional review board approval was obtained, and all patients gave their informed consent before participating in the study. So this is the incision in that is used in minimally invasive posterior approach. It should be 8 centimeter or less than that in MIS technique. The following two graphs demonstrates the pain at rest and pain in motion when doing in both the approaches. The single blue line that demonstrates the standard approach, and the red line with blue boxes demonstrates the MIS approach. The table describes the detail about the participants from mean age. In standard approach, we have taken participants from 71.5 to plus minus 5.6 years. The patient's age ranging from 61 to 86 years. And in mini posterior approach, 71.9 plus minus 6.1 years, ranging from 55 to 87 years. In study, total 19 males and 21 males and 19 females were included. Results: there was no difference between the increases seen in the post-operative muscle enzyme parameters CPK, CKMM, and myoglobin in either group when compared to the pre-operative values. The rise in the CRP values was also comparable in both the groups. In contrast, there was a significantly lower loss of blood in the MIS group, not only in the intraoperative phase but also in the period up to the removal of the drain. In parallel, the standard approach group contained 8 patients who exhibited wound secretion beyond the 7th post-operative day, whereas the MIS group only contained such patients. From a clinical point of view, the patients in the MIS group reported significantly less pain at rest, but not during the movement. This difference in resting pain levels become apparent from the 5th post-operative day. As far as the rate of recovery was concerned, the patients in the MIS group were able to walk along the corridor and climb stairs unassisted at significantly earlier times than the standard approach group. There was no differences in the Oxford hip score or the WOMAC score when assessed 6 weeks post-surgery. The evaluation of the X-ray images did not reveal any differences in any of the parameters used for assessing the two groups. In particular, the MIS group did not exhibit a more frequent malpositioning of the implant. So the conclusion is the minimally invasive operated patients exhibited a significantly lower loss of blood, significantly less pain at rest, and faster rate of recovery. But the clinical chemistry value and the other clinical parameters were comparable. And then following are the references. Thank you, sir.
Very nice presentation, Dr. Modi.
Thank you, sir.
Do you have questions? One question, Dr. Modi, I wanted to ask you. Hello, Dr. Modi, am I audible?
Yes, sir. Yes, sir.
Did you select patients with low BMI for your study?
Sir,
hello. Did you select patients with low BMI for your study?
The patients ranging from all BMI group were included, sir.
But the average BMI in their both groups was 27 and 28 only, which is a pretty lean group for 71 years of age.
Yes, sir, but we selected the patient based on the how they came up in OPD and casualty and ready to give consent.
I request the other participant to please mute while the session is there. Please, other participant, kindly mute your mics. Second is any difference in the long-term results?
No, sir. Actually, studies just completed in December 2021. So more follow-up more than 6 weeks has not been done yet, sir.
Okay. And you have not told any surgical method about the mini incision approach?
So mini incision posterior incision approach, sir.
You should have told something about surgical steps, like how do you do the mini incision approach? How do you do the mini incision? Can you elaborate for our viewers?
Do you have any pictures or video, short video?
No,
any
sir.
Schematic diagram which you can show? Did you use any sort of specialized instruments as we use in direct anterior approach, or the same conventional instruments were used while doing with posterior approach?
No, sir. Nothing. Any special instruments were used.
Not used.
No, sir.
So you did your minimal invasive approach using all your conventional instrumentation.
Yes, sir.
So did you find any difficulty in retracting the muscles?
Yes, sir. Main difficulty was in retracting only. Yes, sir. Yes, sir.
So instead of taking up advantage with respect to enzymatic activity, which you have stated in your paper regarding muscle injuries, so I think that lot of traction, lot of soft tissue injury might have been there if you are going to use your conventional instrument.
Sir, we were used only Homans and the Journeys retractor only. Nothing more than that, sir.
Mm-hmm. Because minimal invasive is not that you give a minimal incision. It is about doing maximal soft tissue salvage with small incisions.
There's another question from the floor, Dr. Amul. What is the difference between that minimal incision approach and the standard approach that he used? What are the key differences?
Sir, minimal incision approach, we use the incision that is 8 centimeter length only, or a 4-finger width incision only, not more than that.
So, and what is the difference when you go inside?
Sorry, sir?
There's a question from Dr. Santosh that what is the difference between the two approaches you are doing? Okay. So any other questions from the floor? So we'll go to our next speaker. Thank you, Dr. Amul. Thanks for the presentation. Next speaker, Dr. Gaurav Kumar Singh, functional radiological outcome of biplane double supported screw fixation in fracture neck of femur. There's one more question from the floor. Dr. Santosh, please ask.
Thank you,
Professor
Dr.
Santosh. Yeah, please ask, sir.
My question is this: when you are saying that you are comparing the two approaches, one is standard, one is so. Please tell us what is the difference apart from incision. See, if you have a lean thin patient, you can go by 8 centimeters in a standard approach. So we are not able to understand the concept between the standard approach and the minimal invasive your approach. What is your minimal?
Dr. Amul, are you there?
Yes. Yes, sir.
Yeah, please answer.
Are you getting me? What I
Yes,
want to ask? Yes. What is the basic difference you followed in both approaches, apart from the incision? See, if you are having a lean, thin patient, you can go for even 6 centimeters incision. I can do the posterior standard approach.
Yes, sir. Sir, actually, in normal, the conventional approach, we cut the all rotators, but in posterior minimal invasive approach, sir, we spare the piriformis, sir.
If you spare the piriformis, then how do you go for posteriorly?
By retracting it, sir.
Huh? I think Dr. Santosh wanted to make a point. It is the size, centimeters wise, you cannot say minimally invasive surgery because a thick patient can be there. Heavy patient might be there. So we'll come back. Meanwhile, please mute your microphones. I request the speakers to please mute your videos. I request our next speaker, Dr. Kumar Singh, to start his presentation.
Good evening, sir. Good evening to all the respected chairpersons. Is my slides are visible?
Yeah, slides are visible. Please continue.
Okay, sir. My presentation is on functional electrical outcome of biplane double supported screw fixation in fractured neck of femur. First, the introduction. The neck of femur fracture is one of the common fractures in elderly. It has always been a challenge to the orthopedic surgeons to manage these kinds of fractures. The prevalence of neck of femur fractures has increasing with increased incidence of osteoporosis, poor vision, and poor neuromuscular coordination, and lifestyle changes and sedentary life habits. There are various implications for the management of this kind of fractures. For displaced intracapsular fracture neck of femur, we have the hemiorthoplasty or total hip replacements. For non-displaced fractures, that can be managed with using CC screws, and the extracapsular fractures who have a compromise to the arterial blood supply to the femoral head and neck, and thus are commonly managed with various types of surgical fixation techniques like PFN and DHS. The material and methods. The prospective study was conducted at Orthopedic Department, SN Mittal College, Agra. Patient were selected from the patient attending emergency department OPD of orthopedics. The source of data was all the cases admitted in SNMC for treatment of fracture neck of femur by BDSF method. The study design was the prospective study design, and the study period was from September 2019 to March 2021. The sample size was minimum of 20 cases were included in my study. The study population was all OPD, IPD patients with fracture neck of femur. Within 3 weeks are included in the study. After taking informed consent, all these patients were undergone surgical intervention with BDSF. Informed consent for the patient. Follow-up was done at 1 month, 3 months, and 6 months of post-operative period. The inclusion criteria is as follows: all the fracture neck of femur age between 18 to 60 years. Both the sexes were male and females were included. The fresh fractures of less than or equal to 3 weeks were included. The exclusion criteria was old fracture neck of femur, pathological fractures, open or infected fractures, fracture with malignant changes, fracture neck of femur with open epiphysis, ipsilateral shaft femur fracture, and trochanteric fractures. Methodology: patients who have presented in emergency OPD services of SNMC Agra. The radiological assessment was done by pre-op X-ray with the X-ray pelvis both hip AP and lateral view in 15-degree internal rotation, and the X-ray hip with thigh lateral view in of affected side. And a post-op X-ray was done after the completion of procedure. The clinical assessment was done for the pain, swelling, deformity, and patient compliance. The follow-up was done by X-ray hip and thigh at 3 weeks, 6 weeks, 12 weeks, and 24 weeks. The clinical assessment was done by straight leg raising test. The analysis of data was done by analyzed by unpaired t-test. The assessment of functional outcome was done by modified Harris hip score, which have following components. The first is pain, second gait, third is functional activity, 4 is absence of deformity, and 5 is range of motion. Total 100 points was there. The less than 70 was considered a poor outcome, 70 to 79 was considered fair outcome, 80 to 89 was considered a good outcome, and more than 90 was considered excellent outcome. The surgical procedures. The new method of BDSF increases the fixation by its innovative concept of biplane positioning of 3 screws, which makes it possible for the screw to be placed at an increased angle so they can lean on 2 solid supporting points. We establish 2 supporting points. The solid cortex of the calcar act as a medial supporting point for the screw. This supporting point works under the pressure. The entry point of the distal and the middle screw in the solid cortex of the proximal diaphysis act as a lateral supporting point for the 2 screws. This supporting point works under the pressure in proximal directions. There are the indications. All the non-displaced fractures of like Garden type 1 and 2 and the displaced fracture are Garden type 3 and 4 in young patients. In younger patients, the possible indications could be all the high functioning, high demand patients who are unfit for the orthoplasty. And the contraindication can be late diagnosed fractures, the fracture with fracture fixation failure, a small femoral head, pre-existing pathologies like pathological fractures, metabolic diseases, rheumatoid arthritis, osteonecrosis, notable hip osteoarthritis. The implant we used 6.5 or 7 mm self-tapping connected screws, which size varies from 100 to 130 mm as according to the patient. Reduction was done by applying mild traction, slight abduction, and internal rotation of the limb are applied, and only the anatomical reduction is acceptable. The approach is straight lateral incision was done on the border of greater trochanter, and the stripping of periosteum of the lateral diaphysis at 67 centimeters performed. The placement and positioning of the guide wires via the concept of biplane positioning developed by BDSF. The screws are placed in 2 vertical directions in lateral view. The distal screw is laid in the dorsal oblique plane. The middle and the proximal screws are placed in the ventral oblique plane. The firstly, we first apply the screw for the distal, apply the guide wire for the distal screw. Its entry point is about 5 to 7 centimeters distally from the lower border of the greater trochanter. In the lateral surface of the diaphysis, the wire is directed proximally at an angle of 150 to 165 towards the diaphysis axis with inclination of the posterior proximally, so that after it touches into the curve of distal femoral neck cortex, tangentially the wire goes into the dorsal third of the femoral head. Thus, the wire also comes naturally in contact with the posterior neck cortex. The middle guide wire is entry point depending on the CCD angle is at 2 to 4 centimeters proximally from the distal wire. The wire is placed at an angle of 135 to 140 towards the diaphysis axis and is inclined towards anterior proximally. So that after it touches onto the calcar tangentially, the wire goes into the frontal 1/3 of the femoral head in lateral view and into the distal 1/3 of the femoral head in AP view. Finally, the proximal guide wire is placed at a point at 1.5 centimeter proximally from the middle wire, and parallel to it, the lateral wire goes into the front 1/3 of the femoral head in lateral view and into the proximal 1/3 of the femoral head in AP view. Now the placement of screw was done. The middle and proximal screws are first because they are perpendicular to the fracture surface. Before placing the middle and distal screw, we overdrill their holes in the lateral cortex by using a 7 mm cannulated drill bit where a bone tap is difficult to be used. Next, we release the foot traction and by hammering a plastic impactor on the diaphysis cortex several times, impaction of the fracture with distal tightening of a screw was done. Finally, the distal screw is tightened in the desired direction by the operator screw and with the help of a cannulated instrument. I prefer the BDSF over the conventional method. The conventional method of femoral fixation by 3 screws is pellets.
I request the participants to please mute their mic.
Femoral neck axis. The entry point of the 3 screws are placed at the thin fragile cortex of the greater trochanter or close to it. The screws are often located near the axis of the femoral neck in the soft distal bone without any cortical support. In conventional method, due to the lack of two solid supporting points, the implant acts statically like a beam on an elastic foundation. The elastic foundation is implemented by the soft cancellous bone. The advantage of BDSF method due to the biplane placement, enough space of the third screw is provided, unlike the classical orthodox method, where use one of maximum 2 implants are placed at the obtuse angle. Due to the increase in the distance between the 2 supporting points, the weight borne by the bone is significantly increased. The entry point of the screw is positioned wide apart from each other, which ensures that upon weight bearing, the tensile forces exert over the greater surface of the lateral cortex, and thus the risk of fracturing decrease significantly. The screw is placed at a highly increased angle, work in a direction close to the direction of the loading force, which guarantees better result for the screw in its role as a beam because of the influence of the sagging decreases. The parameters of BDSF method, the method innovation is laying of the 3 screws in 2 planes, which allows for the entry point of the 2 of the implant to be placed much more distally in the solid cortex of the proximal diaphysis and also to the lean onto the femoral neck distal cortex. Thus, we establish 2 points of support. The solid distal cortex of the femoral neck acts as a major supporting point for the screw, which works under the pressure. The supporting point A, the entry point of the 2 screws of the screw, the distal and the middle in the thick cortex of the diaphysis ensures a second solid supporting point for the screw, a lateral one, which works under the tension or pressure in proximal direction. Supporting point B, the position of the distal screw as as well as of the middle screw, which are achieved by the femoral method in terms of statics, that turns them into a simple beam with an overhanging end loaded by a vertical force. This beam with an overhanging and successfully supports the head fragment, bearing the body weight and transferring it to the diaphysis. The 2 points which I was talking about are the media. The point B is the lateral cortex are here, and the point A is at the calcar cortex. The fixation method of the two methods, as you can see, this is the conventional method and this is the BDSF method. It was mentioned these forces of tension are decreased by 40% with the BDSF method compared to the conventional method of fixation. Besides, with the BDSF method, the entry point of the screw are located wide apart from each other from 2 to 4 centimeters. Which leads to the dispersion of the tension stress onto the lateral cortex over a wide surface and decreases of the fracture risk, contrary to the conventional method with which the entry point of the screw are at a distance less than 1 centimeter from each other, and thus the forces of tension are concentrated over a small surface. The results: in our study, 11 patients were included. The 11 patients presented within one day, and rest of the patients, 7 patients presented.
I request Dr. Gaurav to please hurry up. Dr.
Yes,
Gaurav, please hurry up.
I'm
You already
concluding,
exceeded the time limit.
yes, in our study, male patients were 19, female patients were 8. Majority of patients were in age limit of 51 to 60 years. The mean age was 56.5. The university majority of cases of were RTA. The total 11 cases. Our study cases, the majority cases was of transcervical type, and Powell's type 2 type, and then the Garden type Garden type 3 type. In our study, out of 27 patients were pain free. 5 patients were have mild pain, and patient had moderate pain. In our study, 3 patients had moderate limb. 20 patients were found to ambulating without the help of any support, and some of them needed some support. With regard to the ability to sit for a longer duration, it was found that 18% of the patient could sit comfortably on a chair.
Dr. Gaurav, please conclude.
Yes, sir. With Harris, his score evaluated at maximum follow-up of our patient, we averaged 90.13, with minimum score was maximum was 96 and minimum score was 66. The conclusion: BDSF method was devised mainly to address that group of patients where the orthoplasty is contraindicated, and we have found this as an excellent method in terms of fracture consolidation and functional outcome. By providing additional cortical support, the novel BDSF method enhances the fracture neck of fixation strength and reveals excellent and clinical outcome, and is alternative to the other treatment methods. There are some cases. A 45-year male, 1-day-old injury. This is the pre-op X-ray. This is the immediate post-op X-ray. This is the follow-up X-ray. This is the functional outcome. The 19-year male with
Dr. Gaurav, only one case, please.
Yes,
we already exceeded time limit.
This is functional. Thank you, sir.
Dr. Amrit.
Thank you for your presentation, Dr. Gaurav. It's a nice paper and a new technique which is coming up.
Yes, sir.
So I would request questions from the floor.
Can I ask some question?
Sure,
yes,
sure.
Sir, please.
Dr. Gaurav.
Yes, sir.
Your title was functional and radiological outcome to compare
Yes.
BDSF.
Yes, sir.
Functional radiological outcome and the BDSF. So what was the radiological outcome you have measured? I have not found anything in your thesis.
Yes,
Functional,
sir,
you said that there is only Harris modified Harris score you have measured. But what the radiological outcome you measured? I don't know.
Sir, we measured the radiological outcome by the follow-up X-rays, the union that takes place, and simultaneously we assess the functional outcome of the patients by the.
What you have seen in the radiological outcome? Only union.
Sorry, sir.
In radiological outcome, only union in the follow-up X-ray.
Yes, sir. The union that takes place in the X-rays after we reduce and fix with the screws, the fracture we fix with the screws.
Okay, thank you, Gaurav. Thank you for your presentation. For the constraint of time, we will move on to the
next
session 2. I request the chairpersons and the moderators to please there. Dr. Arun Gupta, sir. Are you there, sir? Am I audible? Moderator Dr. Vivek Mittal, Dr. Gaurav Upadhyay.
Yes, sir. Join the session.
Okay, Dr. Gaurav, please take over. And chairperson, I request Dr. Arunun Sarup, Dr. Navneet Badoni, Dr. Manoj Mittal sir, Dr. Naren Kushwa. Am I audible? Are you there, sir?
Yes, yes.
So we'll start with the first presentation. Dr. Devendra Sharma.
Yes, sir.
From KGMC.
Please
and please share screen and start.
Sir, yes. So is my slide is visible to everyone?
Your slides are very well visible. Please go ahead.
Okay, sir. My paper presentation, sir. My comparative analysis of reconstruction of ACL with quadruple hamstring graft and quadruple hamstring graft internally braced with fiber tape. This is a prospective analytical study conducted in Department of Orthopedic Surgery, King George Medical University, Lucknow, sir. Main objectives. In our study, I compared the surgical technique by evaluating the functional outcome of strength, dynamic stability of the knee muscle after the reconstruction by quadruple hamstring graft and the quadruple hamstring graft, which is internally braced by the fiber tape. And our objectives was to measure the additional effect of using the fiber tape on lysomny score to achieving the fiber tape on post-operative.
Bluetooth off करना पड़ेगा इसका.
Material and method. The study was prospective cohort study. Study duration was 1.5 years, and the study design was prospective cohort study. The study was conducted in Department of Orthopedic, KGMC, Lucknow. Two groups are made by depending upon the arthroscopic surgical technique adopted by the operating surgeon. Group A is consisting the patient who has ACL reconstruction with quadruple hamstring graft internally braced with fiber tape, and Group B contains the patients who have ACL reconstruction with quadruple hamstring graft. Inclusion and exclusion criteria. In inclusion criteria, the patient who has clinical radiological arthroscopic evidence of ACL ligament deficiency, which was symptomatic even after the conservative therapy of adequately duration with normal contralateral knee. 18 to 45 year active motivated patient with future interest in the professional recreational sports who are involved in the vigorous activity and willing to change their lifestyles are included. Acute inflammatory phase of the injury has subsided and full range of the motion and good quadriceps strength has been regained with no extension legs are included. Exclusions, the patient with bilateral ACL is not included. Patient with other systemic disease which compromising their pre-anesthetic fitness is not included. Patient with associated fracture involving their limb, lower limb or other neurological or neurovascular injury or spines are not included. Patient with any other associated ligament injury of the knee like complete tear of the PCL, medial and lateral collateral ligament requiring treatment with significant articular cartilage lesion, whose grade is extending to grade 3 is not included. Patient with ACL reconstruction of the both knee and which has the open physis is not included. Patient with significant arthritis and local institution are not included. Proceed the study as all the patients with unilateral ACL are selected and divided into two groups randomly, and post-operative rehabilitation protocols are followed. What is our operative techniques? ACL reconstruction with quadruple hamstring standard technique everyone knows, sir. The ACL reconstruction with quadruple hamstring graft internally braced with fiber tape. What is our technique? After harvesting the quadruple hamstring graft and preparing it for the implantation in standard manner, a fiber tape which is double in its length is taken and tied with loop of the endo button implant toward the femoral sides. Now endo button was flipped and the graft was fixed with the knee in the 15 degree of the flexion, keeping the screw anterior to the graft for the easy visualization of the tip of the screw. Now fiber tape which is already taken out through the medial portal of the anteromedial portal now settled through the guide wire from the whole of the screw with the help of the lasso and tightly fixed with secondary fixation. Secondary fixation may be done by the bony bridge, anchor and cortical screw, and this second fixation is done in the knee in full extension on the anterior side of the graft. This is our graft and this is the fiber tape which is going along with the grafts. Another diagram which is showing the separation of the fiber tape from the other grafts, and next diagram is showing the other. Rehabilitation protocols. For the both groups, the same rehabilitation protocols was follow protocols. Post-operative evaluation was done at 6 weeks, 12 weeks, and 6 months by lysomny score, and grading of laxity is done by the anterior dover test, Latchman test, and pivot shift test. Observation and results, sir. Group A and Group B are made. Group A contained internally 25 patients. Group B contained standard technique 25 patients. In Group A, it was 16% female and 84% male, while Group B contained 24% female and 76% males. Age distribution.
Devendra, please summarize.
Okay, sir. Okay, sir. In our study, sir, we have found that the anterior dover test and Latchman test, both tests has significant. Both tests has improvement in the grades of the improve in grades, but there is no such significant difference present between the other with the Group B, sir. Like the Latchman test, also in Latchman test, when we test the Latchman test at 6 weeks, 12 weeks, and 6 months, we found that there is no such significant difference, but the improvement of grades are in Group A is much better than Group B, sir. Similarly, for knee extension leg, it was initially present in some patient, but at 12 week and 6 months, the knee extension leg was absent in our patients. So it is not comparable, sir. Pivot shift is done at the 6 months, sir. Initially, it was present in all patients, but after 6 months, it was absent in all patients, sir. Lysomny score in our study, sir, at 6 week, there is no such significant difference in the lysomny score. But at 12 week and 6 months, there is a significant difference between the group A and B in the lysomny score, sir. Discussion, as I compared the 50 patients, among which 24 in group A, 25 in group B, mark this NTL, like the similar study also group the patient in such way. Age distribution, gender distribution, all are similar to at the study conducted by mark this NTL, sir.
Dr. Devendra, please conclude now.
Sir, when we comparing the grade of improvement of various parameters in each follow-up, sir, the interleave brace group improved significantly more at 12 week and 6 months, sir, and that the non-interleave brace group. Our results are comparable to the other study done on the same subjects, but the study limitation factor of our study is that 6 month follow-up duration is a limiting factor. We require more time for this method, for more clinical evaluation is required for the effect of graft protection and the clinical behavior of the resulting fiber tape. Thank you, sir.
Dr. Arun, please unmute yourself. Dr. Arun Gupta, and your comments.
So, nice presentation, Dr. Devendra.
Thank you, sir.
Have you considered the state of pivot shift preoperative vis-a-vis post-operative after 6 months?
Yes, sir. Initially, I go for the pivot shift preoperatively, but after surgery, sir, at 6 months, we go for the pivot shift test, sir.
So, what you have felt from the control, that means a normal side of the patient, since you have omitted the bilateral ACLs, which is rare in TIT.
Yes, sir. Sorry, sir, I
You're
don't
getting the question. You have not analyzed that.
Sir, I'm not analyzed that thing, sir.
Okay.
Any other question from the chairpersons?
You have used the fiber tape with the graft.
Yes, sir.
Is this make any difference in range of movement because the graft, natural graft has a elasticity, but when you are using the fiber tape along with the graft, is there any difference?
Sorry, sir, I did not measure the range of movement pre-operatively and post-operatively, but rehabilitation is better in group A, sir, as compared to group B.
In terms of laxity, you are telling?
In terms of laxity, yes,
okay.
Sir.
Have you differentially, Dr. Devendra, have you differentially tensioned the fiber tape and graft, or in the same degree of flexion?
Sir, actually, graft is fixed at 50 degree of the flexion, and the fiber tape is fixed at
50 or 15? 15.
Sir, 15, sir.
Dr. Nishank, in the meanwhile, start sharing your screen.
Dr. David, please go ahead.
Thank you, sir.
Thank you. Dr. Nishank, are you there?
Yes, sir. Yes, sir. I'm here.
Please start sharing your screen.
Yes, sir. Sir, shall I start?
Please start.
Yes, sir. Good evening, everyone. Today I'm presenting my paper on the topic to find association of neck disability in relation to physical activities among young adults with chronic neck pain. Introduction: the neck pain is one chief musculoskeletal disorder that is noted in adult population and affects approximately 14 to 70% during their lifetime. Musculoskeletal disorders are injury and disorders that impact human body movement due to involvement of musculoskeletal system, that is muscles, ligament, nerves, etc. When the skin, ligaments, and when the skin, ligament, and muscle of neck are palpated, both active and dynamic movements, it causes generalized feeling of hyperalgesia, which is termed as chronic neck pain. In epidemiological studies, pain is said to be chronic if it lasts for more than 3 months. Approximately 2/3 of the individual at some point during their lifetime experience at least one episode of pain in their neck or shoulder. Recently, there is a higher incidence of neck pain due to excessive use of phones, computers, especially among young people. Neck disability is defined as how much the person's everyday activity has been affected due to neck pain. Although neck pain is a common source of disability, a little is known about its prevalence and courses. The aim of my study was to find association between of neck disability in relation to physical activity among young adults with chronic neck pain. The age group was taken between 18 to 35 years of age. The objective was to find patient with chronic neck pain, to identify physical activity among young adults, to find out neck disability in patient with chronic neck pain, and to find out the association of neck disability in relation to physical activity with chronic neck pain. The material, the study was conducted in a hospital after getting clearance from ethical, and total 312 cases were taken with chronic neck pain aged between 18 to 35 years. The exclusion criteria was patient previously operated for any cervical disease, any illness of connective tissue disorder, any spinal deformity, or any history of cervical injury. The methodology: after taking proper consent and clearance from the ethical committee, cases were taken and were divided into 5 groups. The group naming very active, active, moderate active, light active, and inactive based on their physical activity. The level of physical activity was assessed by asking them a simple question on how is their physical activity, that is brisk or light. Brisk is defined as physical activity that causes at least some shortness of breath, sweating, that is brisk, and light refers to physical activity that does not causes excessive sweating or shortness of breath. The neck disability index, after that, neck disability index score was taken after from each cases after asking neck disability index questionnaire. The result of our study showed that total 312 individuals with chronic neck pain between the age of 18 to 35 years of age were taken, where the largest proportion of neck disability was recorded in the age group of 18 to 25 years of age, followed by 31 to 35 age group, that is 59.6%, 24%. However, our study discovered no statistical relationship between neck disability and the age group. In our study, we also found that females were more affected than male. 52% females were affected, then males were 47%, and there was no association between neck disability and the sex of the patients. The result of a study also showed that there was no statistical association between neck disability and physical activity of the cases presented with chronic neck pain, since the calculated value was less than 0.3. Which was found to be insignificant. This is the table, and this is the graph showing the association of neck disability and physical activity. Conclusion: the study adds to the evidence that neck pain is frequent among people between the age of 18 to 35 years of age. According to the finding of the study, there is significant connection between comorbidity of some cases. In this study, we found that there is no significant association between neck disability and physical activity of the cases of the patients. Thank you.
Dr. Nishant.
Yes, sir.
What physical activity did you take into consideration?
So physical activities, we actually define physical activity, sir, as in anything, any work, sir. For example, if the sir उनका जो भी मतलब जो भी उनकी day to day routine activities होती हैं, sir, it could be jogging, it could be walking, sir, या फिर anything, sir, irrespective of the weather, sir. अगर वो sweating और shortness of breath होती है, sir, ऐसी कोई भी strength exercises करते हैं normally, so तो हमने उसको consider किया था.
Your paper is association of neck disability with physical activity.
Yes, sir. Yes, sir.
Physical activity into mild, moderate, and
yes, sir. So we divided on that.
You define these parameters.
Yes, sir. Basically, sir, on the basis of physical activity, sir, less than अगर sir light or brisk जो activities थी, sir, जो patient more than sir 10 hours, more than 10 hours से ज़्यादा जो sweat कर रहे थे, sir, हम उनको very active में रखा था, more than 6 hours से sir light active, and 4 sir inactive, and sir inactive रखा था, sir, less than 2 hours per week, sir.
Per week. And
yes, sir.
How do you do your neck disability?
Sir, neck disability we have asked by simply asking the neck disability questionnaire, sir. Neck disability index questionnaire, sir. So that's a set of questions we asked to the patient. Basically, sir, the total score is 50, sir, overall, and more than 25 is causes, more than 4 score causes proves neck disability, sir.
I have a question, sir.
Yes, sir.
If I may.
Yes, sir.
Sure.
What definition of neck pain you have used? you have taken the patients of chronic neck pain. So what?
Yes, sir. Yes, sir.
Of neck pain you have
Sir, chronic neck pain. Any patient for in which the patient lasted for more than 3 months, sir.
Which area? Because there's
yes,
a standard definition of neck pain according to different questionnaires. So
Yes,
one
sir.
is the pain, ache, or discomfort in the area between the occiput and thoracic vertebra and between the middle borders of the scapula.
Yes,
This
sir.
is one definition I'm just telling you. So have you used any specific definition of neck
Yes,
pain?
sir. Yes, sir. So we actually defined neck pain in the area, sir, from the base of occipital region to the shoulder blade, sir, until the shoulder.
Dr. Jha, please start sharing your screen. Dr. Aditya Jha,
yes, sir.
Please start sharing your screen.
Yes, sir.
Thank you, Dr. Nishank.
Thank you, sir.
Aditya, if you are ready, start.
Yes, sir. Yes, sir. Good morning, sir. Good evening, sir. Sir, my topic is assessment of role of platelet plasma in healing of diphyseal long bone fractures, a randomized control trial. Sir, introduction. According to the World Health Organization, muscular injuries, skeletal injuries are the most common cause of severe long-term pain and physical disability and affects hundreds of millions of people around the world. New researchers are focusing on the use of autologous growth factors to increase the effect of bone fracture healing while decreasing the amount of healing time for the patient. Sir, platelets have been demonstrated to be the natural storage vessel for several growth factors and cytokines that promote coagulation, blood coagulation, tissue repair, and the process of bone mineralization. Aim was to assess the role of platelet-rich plasma for healing of surgically managed diphyseal long bone fractures of lower limb by comparing it with a control group. Objectives, sir, in the cases of diphyseal long bone fractures of lower limb which could be managed surgically by nailing was identified. They were randomized into intervention group and control group. Cortex to callus ratio and time to union was calculated. The results of the two groups were calculated. Material method, sir. Type of study, it was a prospective randomized control trial. The place, it was Department of Orthopaedics Surgery, Dinkar Medical College Research Center, Muradabad. Source of data, sir. Patients with diphyseal long bone fractures of lower limb who presented to the indoor-outdoor Department of Orthopaedic Surgery at TMMC and RC, Muradabad, who were managed surgically. Inclusion criteria, sir. All adult patients having diphyseal long bone fractures of lower limb less than 3 weeks old who were treated surgically. So exclusion, it was patient with pathological fractures and patient having open fractures. Methodology. The patients were divided into two groups, Group A and Group B. Patient study first was number 1 and patient study second were number 2 and so on. All odd numbered patients came in Group A and was intervention group. In this group, platelet plasma was injected at the fracture site. Under the guidance of image intensifier, 10 days after surgical fixation, all even numbered patients came in Group B. In these patients, no intervention was done. Follow-ups. Follow-up was done monthly at the 3 months from the first injection and then in 6th and 9th month thereafter. Sir, tools for assessment in results. Radiological assessment were done at each follow-up, determining cortex to callus ratio on AP and lateral radiographs of the fractured bone and compared with the control group. Radiological caliper measurement of the radiograph were done to determine the cortex to callus width. Maximum callus width divided by the average width of two cortices in close proximity to the fracture line gave the cortex to callus ratio. All the radiographs were taken by same X-ray machine. Sir. Painless full weight bearing on the affected limb was physical requirement for union. Results showed that the statistical set found no significant difference between the distribution of the patients in the two groups with respect to age, sex, and site of fracture and type of fracture. The mean cortex to callus ratio was calculated for the selected groups in all follow-up for 9 months. Case group had better cortex to callus ratio and control group had all 9 months. And the difference was statistically significant on 2nd, 3rd, and 6th months of follow-up. In other months, 1 and 9, though the study group had better ratio, cortex to callus ratio, but the difference was not statistically significant. So this is a table, sir, for it. This is the graph, sir. On comparing these groups for radiological union, the two groups by ANOVA test, there was 7.85 and 8.833 for case group and control group respectively. Statistically significant difference was observed for the two groups. The study population of a study did not have any allergic reaction, infection, or any other complication due to PRP application. This is a CR image of injection, sir. This is the radiological caliper, sir, and this one while injecting the PRP. Discussion. Healing of long bone fracture get hampered due to many reasons. This has led to new research in the field of augmentation of fracture healing process. Platelet plasma injection is safe, cost-effective method which augments in fracture healing. We did this study in TMU hospital. This was done on 54 patients having diphyseal long bone fracture of the lower limb managed by CRI with nailing, FIN for femur and TIN, tibial interval for tibia. Sir, all the patients were divided into two groups, Group A, Group B. Patient studied first one number 1 and patient is second one number 2 and so on. All odd number patients came in Group A and one intervention group. In this group, platinum plasma injected at the fracture site under guidance of image identifier 10 day after surgical fixation. All even number patients came in Group B. In this patient, no intervention was done, sir. Male subjects were more in both groups as compared to female. Cortex to caliper ratio was calculated using radiological caliper and compared within both groups. Time to union was also calculated and compared within both groups. Male subjects were more and cortex to callus ratio was calculated in radiological caliper and compared with both groups. Time to union was also considered and compared between both groups. Cortex to callus ratio was calculated in first, second, third, and sixth and 9 months of follow-up. We found case group had better cortex to callus ratio than control group, but it was steadily significant in second, third, and 6 months. This time to union was less in the case group as compared to control group, which was steadily significant, which were not similar to studies as reported by Gawande et al. And Calvi et al. And Singh et al. Even though being a single center study with a smaller sample size, all the limitations of the study, it is a limitation, but we have tried our best to cover all the parameters required for the same. Conclusion from this study, we conclude that PRP reduces fracture healing time and adjuvants callus formation. The other references, sir. Thank you, sir. Finished.
I have two questions to Dr. Aditya.
Yes, sir.
One, whether the PRP you have used was activated or inactivated?
Sir, activated, sir.
Okay. Second one is, what was the average count of platelets in your PRP?
Sir?
How much?
How much count of the platelets in PRP? You have not mentioned about the count of platelets in your PRP.
Oh, so that we didn't calculate.
What should be, according to you, what should be the average count when you call PRP?
Yeah.
Sir, we take the blood and in laboratory, sir, we make it.
Yes.
And how much? How much PRP injection you give?
Sir, 3 ml, sir.
3 ml.
Yes,
And
sir.
have you tried in delayed union also?
No, sir. Only in fresh fractures.
Only fresh fracture.
Yes,
And
sir.
what was the criteria? I mean, you have said that after surgery.
Yes,
So it depends on the stability of the surgery also.
Yes.
Devesh, start sharing your screen, please. Continue, Aditya.
Yes,
Dr.
sir.
Devesh,
Sir,
start sharing
we
your
took,
screen.
sir, we took
Okay,
lower
sir.
limb, sir, and diphysial long bone fractures of lower limb, sir.
Yeah. But if the fracture is unstable, whatever you give, I mean,
Yes, sir.
PRP or anything, it doesn't matter. The matter is, the most important thing is the stability of the fracture. I mean,
Yes,
if the fracture is stabilized nicely,
Yes,
then the PRP has some role.
Yes, sir. It was stabilized nicely, sir. There was no if it was open fracture, sir. We didn't include it, and it was all the
Dr.
fracture.
Aditya, please stop sharing your screen so that another can do that.
Thank you, Dr. Sanjay.
Okay, thank you.
Can I
Thank
ask
you
a
so much.
question, Dr. Sadana? This is Dr. Atul Srivastava.
Atul, please proceed.
Yeah, Aditya, I am made to believe that you are injecting at 10th post-operative day.
Yes, sir. Yes, sir.
And I may be wrong, but I had learned that this is usually used for delayed or non-unions.
Yeah.
Yes, sir. Yes, sir.
So we are not
osteoarthritis.
giving a chance to Mother Nature to heal.
Yes.
And how do we know whether your PRP has healed the fracture or the fracture would have healed otherwise also eventually?
सर इसी randomized control trial था सर. हमने 50% of patient में सर नहीं दिया था ये. जो मैंने 54 पेशेंट लिए थे उसमें 50% को नहीं दिया और 50% को दिया था. हमने उन दोनों को कंपेयर किया, उनका कैलस फॉर्मेशन जो रेडियोलॉजिकल कैलिपर से मेजर करके कॉर्टेक्स टू कैलस रेशियो निकाला था सर. उससे उन दोनों को कंपेयर किया था.
वो मेरे भाई मेरे को समझ में आ गया, लेकिन जिसमें आपने इंजेक्शन लगाया है हम ये कैसे मान लें कि वो अदरवाइज नहीं जुड़ता? तो इस बारे में सोचिएगा, बस एक थॉट प्रोसेस है.
जी सर.
नाइस प्रेजेंटेशन अदरवाइज. थैंक यू.
Dr. Aditya, Dr. Devesh, please share screen. Start.
Yes, sir.
Dr. Devesh Singh.
Yes, sir.
ये क्या आवाज आ रही है?
Can I start, sir?
Please go ahead.
Good morning. Good evening, everyone. My topic of this is assessment of disease activity score with respect to vitamin D in rheumatoid arthritis, an observational study. Introduction. Nothing is more miserable than to live a crippled and disabled life. Rheumatoid arthritis is a chronic inflammatory disease of unknown cause, which mainly affects the synovium. It is an autoimmune disease with most common inflammatory joint disease accounting for a large percent of disability. There may be involvement of multiple organs and extra-articular system in rheumatoid arthritis. Disease activity score is an assessment used by the clinician to measure rheumatoid arthritis disease activity to determine whether the signs and symptoms have reduced or stopped and if the treatment needs to be adjusted. New evidence shows that the vitamin D deficiency may have a role in inflammatory illness like RA. Vitamin D metabolites influence inflammation in vitro by altering T helper cells and regulatory T helper cell activity. Previous research have shown that supplementing with vitamin D can increase immunological tolerance in RA patients. Some recent studies that summarize advances, the association between the vitamin D and rheumatoid arthritis demands additional investigation. More studies required to validate the association between the RA susceptibility and vitamin D polymorphism, as well as to identify whether vitamin D serves a role in preventing the onset of RA. As a result, more research is needing to identify the effect and ideal dosage of vitamin D supplementation in the therapy of RA patients. Aims and objective. Aims. Assessment of disease activity score with respect to vitamin D in rheumatoid arthritis and observational study. Objective is to identify the cases of RA, to get estimation of vitamin D amount in patients of RA, to find the association between the vitamin D level and the activity of disease of RA. Materials and method. The place of studies, Department of Orthopaedics, Dhankar Mahavir Medical College and Research Center, Delhi Road, Moradabad, UP. Duration of study is January 2020 till June 2021. Study design is observational. Source of data, all patients of rheumatoid arthritis between the age of 18 to 45 years who presented to the outdoor and indoor Department of Orthopaedics, Dhankar Mahavir Medical College and Research Center, Moradabad during the study period. Results. This represents the average age with standard deviation variability. The mean age was 36.38 plus minus 8.2 years, with the minimum age was 19 and maximum was 45 years. Table 2 represents the frequency distribution of cases according to the gender, in which female the frequency of 26 with a percentage of 61.9, male is of 16 and 38. Total is 42 and percentage of 100. Table 2 and figure 1 shows the distribution of gender where the proportion of female were higher than male, that is 61.9 and male was 38.1. This table represents the frequency distribution of cases according to the disease activity level, that is high, low, and moderate, and the frequency in high is 12, low is 2, moderate is 28, and total is 42. This table 4 and figure 3 show the distribution of disease activity level, where the proportion of moderately active level are found is higher as compared to low and high. This table 5 represents the average vitamin D level with standard deviation. The mean vitamin D level was 10.93 plus minus 2.7 with minimum of 7 and maximum was 18. Table 6 represents the average disease activity score 28 with standard deviation variability. The mean DAS28 score was 4.46 plus minus 0.82 with minimum was 2.63 and maximum was 6.08. Table 7 shows the comparison of mean vitamin D and DAS28 score in the disease activity group score. Table 7 shows the comparison of mean in the disease activity group of subjects. The difference in mean DAS score was were found significant as the p-value is less than 0.05. Table 8 shows the comparison of mean vitamin D and DAS28 score in the disease activity score, in which we took the variable vitamin D level and DAS28 score. Discussion. Our observational study was being carried out in the Department of Orthopaedics of the Dhankar Mahavir Medical College and Research Center, Moradabad. The sample size which was being considered is to be of 42 subjects. Starting with the age of study subject, the representation of average age along with the variability of standard deviation shows that the mean value was 36.38 years along with the standard deviation of 8.2 years. The maximum age of the study subject has been noted as 48 years, whereas the minimum age was 19 years. The frequency distribution of the study subjects as per the gender discrimination show the number of females outnumbered the number of males, as it was 69.1 percentage and 38.1% respectively. According to the disease severity, the representation of the frequency distribution of the study subjects has shown that the majority of the study subjects belong to the moderate disease activity, which accounted for 71.4%. The disease severity was followed by high disease activity, which was having a percentage of 21.4%, and the low disease activity at the minimal amount with 7.1%. The representation of the average level of vitamin D along with the rate of variability of the standard deviation has shown that the mean value is 10.93 along with the standard deviation of 2.70. The minimum value was 7 and maximum was 18. The representation of the average DAS28 score shows that the mean value was 4.86 along with the standard deviation of 0.82. The maximum value for the average DAS28 score was 6.08, where the minimum value for the same was 2.63. Following that, the comparison between the mean level of vitamin D along with the DAS28 score in the disease activity came up with some significant results. The comparison in all these
Please
differences.
finish fastly. Your time is up.
Yes, sir. Yes, sir. The comparison in all these difference in the mean value of DAS28 score was found to be significant as the p-values 0.00, which was less than 0.05. But the comparison between the mean value of vitamin D level was not significant as the p-value came out to be 0.13, which is more than 0.05. In our research, the comparison between the scores of vitamin D and DAS28 score calculated across the disease severity group shows for the vitamin D level, the p-value came out to be 0.59, which was not significant since it was more than 0.05. But for the DAS28 level, again, the p-value came out to be 0.0, which was significant. Even though being a single center study with a smaller size of the sample was the limitation of the study, but still we have tried to best to cover all the parameters for the same. Conclusion: this study primarily focused on assessing the activity score of the disease concerning the vitamin D for rheumatoid arthritis cases. A significant association has been found between the comparison of vitamin D level and DAS28 score. Lastly, it can be suggested that the deficiency is very much common within the rheumatoid arthritis patient and acts as one of the leading cause for worsening of the situation in patients suffering from rheumatoid arthritis. Thus, it also needs to be taken into account during the time of examination of patients that there is need of further research for finding out the immunomodulatory, anti-proliferative and anti-inflammatory properties of the same within a vast group of them. These are my references, sir, and thank you.
Divesh.
Yes.
Dr. Baduni, sir. आप पूछेंगे कुछ सर? Please unmute yourself. Dr. Baduni, please unmute yourself.
Dr. Davis, one question to you.
Yes, sir.
Hello.
Yes, sir.
Dr. Davis, one question to you.
Yes, sir. Yes, sir. Yes, sir.
Have you observed disease activity by?
Yes,
Hello?
sir. I have. Yes, sir. I have
audible?
observed disease activity score, sir. I have calculated the disease activity score by the chart, and I have calculated the tender, swollen joints are taken, and also as well as the ESR and CRP of the patients, and I have included in my chart also, sir.
Dr. David, stop sharing your screen. And the meanwhile, Dr. Aditya Seth, please start sharing your screen.
Dr. Davis, one question to you.
Yes, sir. Yes, sir.
When you find that disease activity is much more in vitamin D deficient patient, then
Yes, sir.
you given vitamin D and observe that disease activity goes down on that patient. Have you observed in your study?
No, sir. I have not taken in this study. But as I have these patients come for the regular follow-up, so I have observed in these patients. There is significant improvement in these patients, sir.
In the
After
disease
giving vitamin D.
After giving the vitamin D, there is significant improvement in the disease activity score. So,
did you estimate the vitamin D level after giving the vitamin D?
no, sir. In this study, I haven't.
Okay, so so how did you assess that this improvement in the disease process is because of the vitamin D? Because you have not assessed the vitamin D level after giving the vitamin D in these patients.
Yes, sir. Due to cost issues, I haven't been able to assess that, sir.
Vitamin D level. Okay.
Yes, sir. Actually, in our institute, a cost of vitamin D level is approximate 1,000 to 1,100 rupees. So patients generally is of a low socioeconomic status. So I haven't been able to, sir, assess after giving.
Thank you, Dr. Devesh. Please stop sharing the screen.
Thank you, sir. Thank you, sir.
Thank you, please.
Thank you.
Dr. Aditya, are you there? Dr. Aditya Seth. Dr. Aditya Seth. Dr. Shashank, are you there?
Yes, sir. Yes, sir.
Aditya Seth नहीं है? So Shashank, please share your screen.
Yes, sir. Am I audible, sir?
Are you audible? But your screen is not visible.
Yeah.
Is my screen visible, sir?
Now it's visible.
Just a second, sir.
Sure.
Good evening to all the faculty members present here. Thank you for giving me the opportunity to present my paper titled Modified Trailing Technique of Arthroscopic All-Inside Anterior Cruciate Ligament Reconstruction Using Autogenous Semitendinosus Graft, an Innovative Approach. The surgical technique of arthroscopic ACL reconstruction continues to evolve, and it has evolved from conventional single bundle ACL reconstruction to anatomical double bundle ACL reconstruction. The technique of bony tunnels has evolved to more bone preserving bony sockets as an all inside technique. The standard trailing technique made use of a Y-shaped configured graft which provided increased rotational stability by recreating the anatomic functional anisometry of the two bundles of the ACL. But it had its own limitations as the graft was configured outside and it was not possible to orient AM and PL bundles anatomically. Also, differential tension couldn't be produced in both the bundles. To tackle these issues, a novel technique of modified trailing technique was innovated, which gives added advantage over the standard trailing technique by tackling tunnel conference related issues, also giving better orientation and providing differential tension. My aims were to evaluate clinical and radiological outcomes of the same technique by using autogenous semitendinosus graft. It was a prospective clinical study including 15 patients, which were then followed up for 6 months post-operatively and included clinico-radiologically diagnosed symptomatic cases of complete ACL tear with unstable knee in the age group of 18 to 60 years. The patients having pre-existing degenerative changes in the knee with other ligament injuries or any history of previous knee surgeries and acute ACL bony avulsions were excluded from the study. The patients were evaluated preoperatively by proper history and examination with KT1000 study and evaluation of various knee scores such as IKTC, Lysome, Tegner, and Q score. Also, proper X-rays and MRI was done preoperatively. Coming on to the surgical technique, first that arthroscopic portals were made, diagnostic arthroscopy was done, and torn ACL was visualized. The graft was harvested from semitendinosus only and was prepared into two bundles of AM and PL. The femoral footprints were prepared followed by drilling of first AM socket, followed by PL socket. Similarly, the tibial footprint was prepared and tibial socket was prepared using a flip cutter. The graft was deployed using suture shuttles with endobutton and procinch on the femoral side and plain endobutton over the tibial side. The passage of the graft, this is the most crucial step of the technique. When after passing of the PL graft was passed, after passing of the PL graft, the suture shuttle was deployed anterior to the PL bundle, giving its proper orientation of the AM bundle. This is the final picture of the graft after passing AM bundle through the tibial tunnel also. The graft was fixed at the tibial end using endo button, and final tensioning of the graft were done differently with PL bundle in extension and AM bundle in 90 degrees of flexion. Then notch impingement was assessed. Then the post-op evaluation of the patient was done at post-operatively, post-op at 3 months and post-op 6 months by various scores, IKDC, Lysome, Coos, Tegner, and clinical examination also. And KT1000 study was done at 6 months only. X-rays and CT scan was done at post-op day 3. CT scan was done at post-op day 3 and at 6 months, and MRI was done at 6 months to assess healing and vascularity of the graft. As we observed and got through a course of 6 months, the laxity of the patient improved, and there were good outcomes with the graft with accelerated rehabilitation. 3D CT was employed to calculate the proper position of the tunnels as well as dilatation of the tunnels at 6 months. MRI was done to assess the graft healing at 6 months, and all our subjects showed good ligamentization at 6 months, which is comparable to the literature. These are the studies done previously by Connaughton et al. And Mayer et al. For tunnel dilatation of the CT scan, and by Connaughton et al. For IKDC and Lysome scoring, which the results were comparable and a bit better than the previous studies. There were no major complications in terms of infection, graft rupture, restriction in range of motion, or any cartilage or meniscus injuries. In conclusion, I would say that the placement of 2 different stands in place of a Y graft provide the ability of differential tension over the 2 bundles, giving it better orientation intraoperatively and mimicking natural knee kinematics and native knee anisometry, similar to the anatomic double bundle ACL reconstruction technique. Thank you.
Hello. Hello, Dr. Shashank.
Yes, sir.
This is Dr. Arun Gupta. Have you measured the footprint on tibial and femoral side? What is the dimension of native ACL footprint?
Sir, preoperatively, we have, I know that preoperatively some of the techniques are doing preoperative measurement of the footprint of the femoral and tibial side, but we have not done that.
So you have subjected all the patients for this Y-link graft, double bundle.
Yes, sir, yes, sir, but intraoperatively it was assessed that whether the footprints was long enough to subject the patient to tri-link or not. Otherwise, if the footprint was small, as in female patients, since all the patients were male, in female patients it was found that the femoral footprint was small, so they were subjected to single bundle ACL by all inside technique only.
And what I am understanding that there is only single tibial tunnel.
Yes, sir. Single tibial tunnel and 2 femoral tunnels.
So how then it will act like a double bundle when the tibial tunnel is single? Can you explain that?
Yes, sir. Sir, by looking at the native anatomy of the ACL, it has a broad shape femoral insertion. At mid substance, it is a bit narrow, and at tibial insertion, it then spirals around and gets broader. So by creating the 2 femoral tunnels, I have covered up the femoral insertion for the ACL by spiraling around the AM graft anterior to the PL graft. I have created a narrow mid substance, and only by a single tunnel, single socket at the tibia, I have converted a broad insertion at the tibia. mimicking the native knee anisometry.
Okay. Nice presentation.
Thank you, sir.
One question to you.
Yes, sir.
Excuse me. Operatively, when you decided you have to do bilink graft, or you have to convert it to go single graft only in your study?
So if the femoral insertion of the graft was the femoral footprint of the graft was too small, then we decided to do it as single bundle ACL, like in female patients.
How many cases you converted to single portal to the femoral side?
So
in your study, how many cases you have converted to single tunnel to femoral side?
I have not included those patients in my study, but during the time, we had converted around 3 to 4 patients.
Okay. Thank you.
Thank you, sir.
रुक गया.
Hello, am I audible?
Yes, अब सुनाई दिया. नहीं, रुक गया था.
Dr. Baduni sir.
Yes, sir.
Sir, overall इस सेशन के बारे में सर आपका क्या कमेंट रहेगा सर?
It was a very good session. All have a good presentation. All PGs have done a very nice presentation.
Sir.
And especially some just as he has presented a trialing technique, that was a new technique. And some other have also a very good presentation. So overall, it is a very good, nice session.
Good presentation.
Yeah.
Dr. Mittal sir.
Yes, it was a nice session, and new chaps are doing good job. Indeed, they are doing good job, and particularly I must say that such type of session are really very good to encourage the younger generation, because in our conferences they get little time, and this is exclusively for young people, so it is very good to encourage them. I really appreciate this type of conferences. Really very good session.
Dr. Narendra Kushwaha.
Very nice arrangement done by you, sir. And all the new arthropods done good job. Nice presentations, all of them.
Dr. Arvind Surup sir. Dr. Arun Gupta. 2 papers थे arthroscopy पर.
Fantastic presentations by the new chaps, and I'm surprised by the high level of work done by the youngsters.
Yeah.
And it's really kudos to the team, Dr. Sadana, Dr. Pal, and the other team members for such a nice, fantastic, and enlightening session.
Thank you, Tarun. We'll now conclude this session and move to the next session. And I can see already our chairpersons are joining. Dr. Dhiren Singh has joined. Santosh Kumar sir has joined. Dr. Manish Khanna. Are the speakers of next session here? Dr. Tinku Singh. Dhiren sir, welcome.
Good evening. Thank you.
Welcome to this E-Pgcon. Tinku Singh, is he here? धीरेन सर आप कुछ प्रकाश डालिए.
Yes, sir.
हाँ सर, इस नए प्रयास पर इसको नया प्लेटफॉर्म मिले.
It's a very good effort. E-Pgcon,
sir.
This PG thing is very good. I mean, digitally it should be done so that they are not left behind. That's very good.
क्योंकि सर नॉर्मल कॉन्फ्रेंसेस में पीजी को कम टाइम मिल पाता है
जी,
तो ये प्रयास है कि हमारे पोस्ट ग्रेजुएट्स अपने टीचिंग डेज में कुछ प्रेजेंटेशन करें ताकि दिस निच जो प्रेजेंटेशन में आती है वो ना रहे.
नेचुरली बच्चे अच्छे करेंगे तभी तो हम बड़े होंगे.
बिल्कुल सर. टिंकू, are you ready?
Yes, sir.
If you are ready, we can start.
Yeah.
Tinku, if you're ready, we can start. Welcome, Dr. Harish. Dr. Tisani.
Yes, sir, present, sir.
Yeah. Tinku, if you're ready, you can start.
Sir, कुछ टेक्निकल प्रॉब्लम. सर टेक्निकल प्रॉब्लम हो रही है.
कोई दिक्कत नहीं है. You can take your own time. डॉक्टर आशीष सर अभी सुन पा रहे हैं मुझे? आपकी स्क्रीन टिंकू शेयर हो रही है. आपको सिर्फ अपना प्रेजेंटेशन ऑन करना है बस.
सर खोल नहीं पा रहा है सर.
तसल्ली से करिए, कोई घबराहट की बात नहीं है.
Just do one thing. Open the PowerPoint first. Currently unshare it. Open the PowerPoint first. Then click on share screen. On the share screen option, you'll see the PPT. There will be one option where that PowerPoint will be. Then share that PowerPoint. Don't share the screen complete. Open the PowerPoint first. Then come back to Zoom. Go to share screen, the green button down.
I think.
Yes, we can see it. Go to the first slide, and then you can start your PowerPoint, the presentation mode. Yeah, move it up. You can off your video. I think your internet is a bit low bandwidth. Go to the first slide first. Are you doing on a phone?
No, sir, laptop.
Dr. Akash, are you there?
Yes, sir.
Can we start with Dr. Akash? In the meantime, Dr. Tinku can resolve his problem.
Yeah, we can start with Dr. Akash.
Dr. Akash, please start sharing your screen.
Ashwani sir, Dr. Akash and Dr. Tinku both are together there. So
Okay.
better let's start with third person.
Third speaker,
Next
Dr. I think his screen is coming. Dr. Dinesh. Dinesh Kumar.
Dr. Akash.
Okay, Dr. Akash. Okay. Dr. Akash, can you start? Are you ready?
Hello.
Haji.
Sir, am I audible?
On Tinku.
Not a started because host has
Hello.
stopped it. Sir,
is it Dr. Akash?
There's a technical problem, sir. Someone has stopped my video from there.
नहीं, टिंकू बोल रहे हैं, आकाश बोल रहे हैं?
Sir, आकाश बोल रहा हूँ।
आकाश आप नहीं कर पा रहे अभी?
Both of them are together.
Together. Okay. Dr. Deepak Kumar, is he there? Third speaker.
Right. Ashwani, maybe his video is not working, but we can see his presentation, so he can do it without video. So let him start with the...
Akash, you can start your presentation.
Yes.
I think you can see your screen.
Okay. Good evening, sir. Hello. Am I audible,
Go
sir?
ahead, Akash. You can start. We can hear you and we can see you. Go ahead.
Go ahead.
Okay, sir. Thank you, sir. So, good evening, everyone. Sir, I'm going to present my research work, that is medial versus anterolateral LCP. In the management of fracture distal tibia, which is a retrospective and prospective study. Sir, as we all know, that the most often fractured long bone is tibia, and because of its subcutaneous location, it is prone to injury, and there's roughly 26 per 1 lakh population each year which suffers from this injury. And there are many ways we can treat distal tibial fractures, that is by interlocking or open reduction internal fixation, by minimally invasive plate osteosynthesis, and by external fixator if there is a wound. Coming to the research question, are there any clinical or functional outcome differences between medial LCP and anterolateral LCP in the treatment of fractured distal tibia? And the aims and objectives are, my research aim is to study the management of fracture of distal tibia using anterolateral distal tibia locking compression plate and medial distal tibia locking compression plate. My objective is to assess and compare the clinical and functional outcome of distal tibia fracture using the anterolateral LCP and medial LCP in terms of pain, function, and alignment using AOFAS, ankle hindfoot scale. Distal tibia locking compression plate and medial distal tibia locking compression plate. My objective is to assess and compare the clinical and functional outcome of the ankle hindfoot scale. Each movement is of 30 points. Yes, sir. Sir, am I audible?
You're audible. Please go ahead.
Yes, sir. You were asking some question.
Go ahead.
Okay, sir. Its grading has been given here, that I have graded 90 to 100 is named excellent, and those who have grading lying between 80 to 89 considered good, and those who are lying between 70 to 79 is considered fair, and less than 70 is being given poor grading. Material and methods used by me. This study is being done in our department, orthopedics department, UPMSFI, and it is being conducted by taking 60 patients. We have taken, because my study is retrospective with prospective study, so I have taken the records of the patients from the record book, and I have taken last 5 years patient list, and from that patient which was of my interest, I have taken the details from the record book, and it is from January 2015 to August 2021, and the rest of the study is being conducted in last 18 months, which is prospective study. And total patient that was taken by me is 60%. And I have divided into two groups, that is anterolateral medial LCP treated group and medial distal tibial LCP treated group. The study design, the study period, and the study sample size, which I have already told. My inclusion, these are the inclusion and exclusion criteria. I have considered only closed distal tibia fractures and open fracture, that is Gustilo-Anderson type 1 fractures only. And those who have compound fractures grade 2 and grade 3 been excluded. And those who are having severe soft tissue injury, those were excluded from my study. This is anterolateral plating being done in our orthopedic department. The images are there, and the incision being displayed here. Features of anterolateral distal tibial screw technology with conventional plating techniques. These are anatomically shaped plates, have both is made for right side and left side both. Shaft holes except locking screws of 3.5 mm. These minute details is being given here. And this is medial plating, the incision line, and this is being done with minimal invasive plate osteosynthesis technique. And this is the clear features, the salient features of the medial distal tibia LCP. My observations and results. Age-wise distribution is being compared between group A and group B. With the group A is the patient treated with anterolateral distal tibia LCP, and group B is considered, the group B in my study is the patient who were treated with medial distal tibial LCP. Overall, the group A age group, the most common age group that was having in group A was 31 to 40 years of age group, and
Dr. Akash, please conclude fast.
Okay, sir. Sir, coming to the day of presentation, most common day of presentation was 3rd to 5th day. Interval between injury and surgery. Most common interval was 9th to 12th day, and the OTA fracture classification, under which I have studied this 43B was the most common OTA classification group. Complications. Most of the patient doesn't have any sort of complication. The most common complications were infection, wound dehiscence. Some patient had malunion, and very few patient had non-union. This is the outcome measurement grade. Most of the patient of group A lied in fair group, and most of the patient of medial plating group lied in under. So my mean clinical score of AOFS was 76.9 with standard deviation of 8.51 in medial plating. And I have compared with other literatures like Padmanov et al. And Gulabi et al., JJ Gyo et al. The study was almost comparable with these journals, which have been published by these fellows. These are the clinical pictures. First one is at the time of injury, and then after surgery, and after 6-month follow-up. And it is being clicked after 6 months, the clinical pictures of the patient. This is medial plating at the time of presentation, at the time of injury, then after surgery, and then after 6 months. And this is clinical picture. So I have summarized all the work I have done. That distal tibial fracture are commonly affecting the middle age group, 30 to 40 years, and incidence are higher in male. Right side is being more affected.
Akash, please conclude now.
Okay, sir. Functional outcome was favorable. That means excellent, good, and fair in 90% of the patient and poor in 10% of the patient, in both the groups, anterolateral plate and distal tibia LCP, both. The anterolateral LCP and medial LCP have more or less similar functional outcome, but the main point was that anterolateral LCP yields good clinical and functional outcome with less complications in these fractures. Thus, we can conclude with the message that internal fixation with pre-contoured locking compression plate, middle anterolateral plate in treatment of distal tibial fracture is a good option, and anterolateral locking compression plate yields good outcome with lower complication rates. And this is all what I have to say. Thank you.
Thank you.
Thank you.
Thank you, Dr. Akash. Any questions from the chairpersons? Santosh
Dr.
sir.
Akash, Dr.
Yes, sir.
Akash, what are the indication of the medial and anterolateral plating?
In the management of distal tibia fractures, sir, medial and distal tibia, medial and anterolateral plate.
So when you use the medial plate and when you use the anterolateral plate, or you in any fracture you can use the any plate. What is your concept?
What he wants to say is the fracture configuration more important, or you can plate medially or laterally? Anyway.
No, sir, fracture configuration is important.
Important.
So when you use the
I think that's okay. The message has been given. I would just like to add one thing. You said your inclusion criteria was a fracture of distal tibia which is not having severe soft tissue injury. You
Yes.
mean to say you included only low energy trauma?
No, sir, I was talking, I didn't said that. I said that open injury is being excluded, sir.
No, you said compound fracture and severe soft tissue injuries were excluded.
Yes, sir. The compound fracture with severe soft tissue injury is being excluded from my study.
Mostly they are high energy trauma and they have a lot
Yes,
of.
sir. Mostly they are high energy trauma.
Right.
Dinku, are you ready with the presentation?
Yeah, second speaker.
Thank you,
Dinku
sir.
Singh. Dr. Tinku Singh,
Yes, sir.
am I audible to you?
Yes, sir.
If you are ready and start sharing your screen. Or there is some still a technical glitch.
Screen, sir, aa raha hai, sir?
First of all, Dr. Akash should leave the screen.
Or he can use a screen of Dr. Akash only.
No problem.
Ask him not to share the screen now.
Dr. Akash, sir, I think they have got one screen only.
to share the presentation.
सर
Now
मैं
they
डॉक्टर
open the
टिंकू आ गया हूँ सर.
डॉक्टर टिंकू आप आ गए ना, तो अपना स्टार्ट शेयरिंग योर स्क्रीन. I think your screen. Start your presentation. In the meantime, we'll welcome Dr. Manish Khanna, sir.
Yeah, good evening.
Sir,
Sorry,
आपके
I
comment.
was, yeah,
Yeah.
I was late actually. I was having a fellowship program, so I was late. I'm sorry.
Okay, thank you, sir.
Sir, audible?
Are you audible, Tinku?
Yes, yes.
We'd like to see your presentation.
विचरता चल रहा है. अच्छा अच्छा, अभी तो बहुत टाइम है फिर.
नहीं, एक दो स्किप भी है ना सर.
सर ये है कंपैरेटिव स्टडी बिटवीन एनाटॉमिकल लॉकिंग कंप्रेशन प्लेट वर्सेस एनाटॉमिकल वेरिएबल एंगल प्लेट. वेरिएबल एंगल आती है ना, वेरिएबल एंगल. ये है डिस्टल फीमर.
डॉक्टर सैनी साहब प्लीज अपने को म्यूट कर लीजिए.
सर आ रहा है सर?
हाँ आ रहा है. टिंकू स्टार्ट करिए.
Good evening, sir, respected teachers. I am here, the Dr. Tinku Singh, JR3 Orthopaedic UPMS. My thesis work on the topic role of the vacuum assist closure therapy in the various types of musculoskeletal injuries. Here the showing the back machine, different size of the foam and canisters. Wound healing is a complex and a dynamic process that includes an immediate sequence of the cell migration leading to repair and closure. The sequence starts with the removal of the debris, control of the infections, clearance of the inflammation, angiogenesis, deposition of the generation tissue, contraction, remodeling of the connective tissue, matrix, and maturation. When the wound fails to undergo the sequence of the event, a chronic wound without anatomical and the functional integrity result occurs. Types of the wound healing. Primary wound healing refer to when the doctor closes the wound using the glue and staples and stitches. And then primary wound healing is the minimal scarring occur. And the secondary wound healing occur when the wound that cannot be stitched causes a large amount of loss of tissue. And the tertiary wound healing occur when there is the need to delay the wound closing procedure. The wound is purposely left open. The staging of the wound healing. The 3 stages: coagulation and inflammation stage, cell proliferation, and repair of the extracellular matrix. Third is the remodeling phase. These are characteristics of the wound dressing. Promote the wound healing, maintain the moisture environment, pain control, odor control, non-allergic, non-irritant, permeability to gas, safety, non-traumatic removal, cost effective, and convenience. My research question: does vacuum assist closure therapy in the various types of the musculoskeletal injury give better functional outcome? Yes, sir.
Yeah, please continue. Please continue.
Aim and objects. To compare the efficacy of the back therapy with the conventional dressing in the term of the wound management in the open musculoskeletal injury based on the following parameter. Number 1, duration of therapy in days, decrease in the wound surface area, rate of granulation tissue, improvement in the BAT score. Method and materials. His study is hospital-based interventional study conducted in the department UPMS API. The comparative study design is a comparative type prospective interventional design. And the sample size 76 patients, 14 the back group and 36 the control group. Inclusion criteria: open Castillo Anderson type 2, 3A, 3B, not type 3C. Exclusion criteria: pre-exiting osteomyelitis bone, neurovascular deficient limb, malignancy, and patient not willing to participate in the study. Technique of back therapy, sequence of the applications. First of all, wound preparation, then placement of foam, third the sealing or drape, and then application of the negative pressure. Controlled pressure is uniformly applied to all tissue on the inner surface of the wound. The foam dressing should be compressed the response of to the negative pressure. The pump can deliver either continuous or intermittent negative pressure. Pressure ranging minus 50 to 125 mmHg. And intermittent delivery consists of 7-minute cycle, 5 minutes on and 2 minutes off. And the optimum setting. The ideal negative pressure setting is the minus 125 mmHg. Mode of action: the back therapy, wound contraction whether causing the
mechanical effect of the cell and remove the edema, harmful infectious agent and enzymes from the wound bed and formation of the granulation tissue and increase the blood supply by the forming the new blood vessels. Ranging of pressure of the wake machine. In the standard is 50 to 125 mmHg, new need 125 to 200 mmHg, children less than 2 years 50 to 75 mmHg, more than 2 years 75 to 125 mmHg, adult minus 125 mmHg. Complication of back therapy. The complication in the back therapy associated with the back system, just like the loose of the seal, power failure, blockage of the drainage, wound infection, pain, bleeding, allergies, and the observation and results. Yeah, the first slide showing the age distribution. The my study having the more patients in the 21 to 30 years. Second age distribution, more patient in the male, and the Gustavo Anderson, the more patient in the type 3B, and the most common mode of injury is the RTA, road traffic accident. Here the summarize the duration of back therapy, decrease in the wound size, rate of granulation tissue, improvement in the wound bed score. Here the duration of therapy is the lesser in the back group as compared to control group. As a decrease in the wound size in the more in the back group as compared to control group, and the rate of granulation is the more in back group as compared to control group, and the improvement in the back group, the improvement in the bed score the more as compared to control group. Here the summary we have already discussed, and the conclusion. The back therapy is totally safe and under no complication, cost effective, superior over the conventional dressing based on the parameter reduction in the wound size, rate of granulation tissue, wound bed score. The healing is the better.
Thank you, Dr. Tinku.
Thank you so much, Dr. Tinku. A small point which I want to ask from you is, you have mentioned in your study that it is single binding type. Can you specify what is actually you want with the single blindings type of the studies?
सर पेशेंट को हमने नहीं बताया कि हमको करना क्या है सर, हमको पता है और सर पेशेंट को पता है हमको.
So in your informed consent, you have not mentioned the details.
सर लेकिन अगर पेशेंट अगर नॉट बिलिंग,
जब आप बता ही नहीं रहे तो नॉट विलिंग और विलिंग का क्या मतलब?
See, the informed consent should have all the details now. So if you are not telling the patient, then it will be a difficult issue later on. You have to, either you should not do a single blinding type of a study. If you are doing it, then you have to do it properly.
Dr. Tinku, how many days you changed this dressing?
Yes, sir.
After how many days you change the dressing in a large wound?
3 to 4 days.
3 or to 4?
Back
3-4 days. Okay.
72 hours, sir.
So it is two. And how much cost of
48 and
one
72
dressing?
hours, sir.
How much cost of that one dressing?
सर हमारे यहाँ तो सर अभी free of cost था सर.
You purchase the foam and canister is for one time and machine is for one time, but I think you purchase the dressings foam, or it is free of cost is available.
सर यहाँ हमारे सर यहाँ संस्था.
Okay, that's good. That's good. Because it is too costly to change every time.
Deepak, are you there? Deepak Kumar, you can start sharing your screen. Dr. Deepak Kumar.
Good evening, sir.
आप हैं ना?
Am I audible? Yes, sir.
Yeah,
Am I audible, sir?
Audible.
Good evening,
Dr.
sir.
Tinku, stop sharing your screen.
Yes, sir.
आप अपनी स्क्रीन शेयर करना बंद करिए तो फिर डॉक्टर दीपक शेयर कर पाएंगे.
Yes, sir. Thank you, sir.
It is requested to everyone that as soon as you stop your presentation, please stop sharing your screen so that the next one can do it.
Good evening, sir. Sir, am I audible, sir?
You're audible, but we can't see your screen. Start sharing your screen.
Sir, I have already shared.
No, we can't see actually.
The green button down. You can start.
Okay, sir. Just a second.
Sure. Take your time. Good. I think it was right now.
Is it visible, sir?
It is visible, but you put your presentation. Yes.
Yes, sir. Sir, I was instructed to give video recorded PowerPoint and to be present online during the presentation to answer the question. Therefore,
Okay.
sir, I have this video saved PPT and I am ready for the questions
Okay.
thereafter.
You play. I don't know if it will be. Okay. Start. I think we gave email sufficiently in advance कि आपको question. Anyway,
Have you started?
Deepak.
Have you started, Dr. Deepak?
Dr. Deepak, if you start speaking with along with your videos, we can't hear you.
His video presentation is already on, I think, but we are not able to hear it.
Dr. Deepak, can you hear us? Dr. Deepak, unmute करिए अपने आप को.
I think he has some internet issues.
Dr. Deepak, we can see you. We can see your screen. We can't hear you.
तीसरा नंबर इसका नहीं होता दूसरा नंबर हो रहा था तो दीपक का भैया फोन करवा
I think his voice recording has not been transferable properly.
Dr. Deepak, अपने आप को unmute तो करिए पहले.
I think he should give a chance after the other speakers.
Dr. Deepak, आप इसके बाद
Either we can ask him to give this presentation later on. We can directly come to the discussion also.
No, it is better. It is better to give him chance later on.
Dr. Dipanshu, are you there? Dipanshu Maheshwari?
Yes, sir, I am there, sir.
Dr. Deepak, please stop sharing your screen and give the screen to Dr. Dipanshu Maheshwari. We can come back to you later.
Organizer can be in touch with Dr. Deepak and ask him to, maybe he's muted his phone actually.
I think he has some internet issues so that he can't see him.
He cannot hear us, so he cannot stop sharing his screen.
So call him on phone. Organizer, please call him on phone.
Since he has finished the presentation, so as soon as he's unmuting himself, then we can directly ask him whatever the chairperson wants to ask.
Basically, his research question is fixation versus arthroplasty. That's what I understand.
Yeah.
And he's almost through. Now we can directly ask him.
Yeah, correct. Please.
Dr. Deepak.
Can you hear us?
Dr. Deepak, can you hear us?
Yes, sir.
चलिए दीपक, हम आपकी बात नहीं सुन पाए, केवल स्लाइड्स देख पाए. Chairpersons.
Yeah, first of all, I just want to ask Dr. Deepak, you told that primary cemented hemiarthroplasty, you feel it's better as compared to the other modality. So what are the silent feature which makes you to think in that way that it is really better in this case, in these cases, sorry.
Sir, my study was for elderly patients, more than 60 years of age. So many of them were osteoporotic.
Dipanshu, in the meantime, please share your screen. Deepak, continue speaking.
Yeah.
Yes, sir. So many of the patients were having osteoporotic type of bone. So fixation was less appropriate as it has complications like malunion, non-union, and implant-related complications like Z effect for PFN and screw cutout in DHS.
Perfect. So so now you want to say that this is a better alternative. Definitely, we do agree. Now the question is, what are the complications which are commonly being seen in these cases? Because every coin has a plus and minus, so that we have to take care of. Yeah.
Yes, sir. In cases of this hemi replacement cases, patients are having this dislocation and aseptic prosthetic loosening, and
so you have to mention, tell them that with the guarded prognosis, how to go for it, what are the do's and don'ts and everything.
Yes, patient. Yes, sir. Patients are advised not to sit cross-legged, and squatting is avoided.
At least in the initial period, right?
Hello?
Because later on the patient do whatever they feel like. Yeah, that's all from my side. Thank you.
Dr. Deepak.
Thank
Dr.
you.
Deepak,
Yes, sir. Yes, sir.
And you, in your study, have you used the long stem or short stem in arthroplasty?
Sir, I have used, in some patients, I have used long stem, and in some cases, short stem, depending on the
fracture in which use short stem.
Sir,
Which type of short stem and which type of how to decide?
Sir, in AO31, A2.1 fractures, I have used short stem, and in fractures which has hello, जी sir.
Hello.
In fracture, yes, sir. In fractures with posterior medial combination, I have used long stem.
Posterior medial combination.
Dr.
And
Deepak.
fix the abductor. What about? What do you abductor fix on the stem, over the stem, or either fixed over the bone?
Sir, abductors was fixed over the bone, and sir, yes, sir. A fragment, greater trochanter fragment was cable circulars.
So what is the advantage of?
I think, sir. Hello.
Let me ask the last question. Doctor, you are sending a message that beyond 60, all intertrochanteric fracture should be replaced. That's what the message you want to pass?
Sir,
You said 60 years.
sir, in my study, it was a better option in cases of patients having osteoporotic type of bone and comorbid patients. What I have concluded, sir.
Okay.
I have also mentioned in the conclusion that fixation has less operating time and less blood loss. But yes.
And Panshu, please
Yes, sir.
start.
Am I audible, sir?
Hello.
Hello, sir. Am I audible?
Yeah,
sir?
you are audible. You are
Screen
audible.
visible?
Yes, visible. Please go ahead.
Good evening to all. I'll be presenting the topic on evaluation of results of laminectomy with short segment pedicle screw fixation in thoracolumbar fracture. Fracture of dorsal lumbar spine is one of the major causes of disability in the current adult population. Dorsal lumbar junction comprises T11 to L2 vertebra and is the most mobile segment which is prone to injury. Laminectomy with pedicle screw fixation is an excellent option for the patient with thoracolumbar fracture. It not only decompresses the spine but also provides stability. The aim of my study was to evaluate the neurological recovery in dorsal lumbar fracture following laminectomy with short segment pedicle screw fixation. Second was to evaluate the correlation of functional recovery with Cobb's angle, anterior wedge angle, and the vertebral height. Third was to assess the effect of vertebral height, Cobb's angle, and anterior wedge angle over the post-operative pain in dorsal lumbar region. The methodology was it was a prospective interventional study conducted in my college in UP for a period of 1.5 years. Neurological recovery of the patient was assessed using ASIA scoring system in pre and post-operative patients. The 6-month post-operative functional recovery in dorsal lumbar pain were correlated to components of anatomical reduction like vertebral height, Cobb's angle, and anterior wedge angle. As per the inclusion criteria, I included the patient having 1 or 2 vertebra fracture within the age of 20 to 60 years, patients having intact pedicle at the vertebral level above and below, and thoracolumbar injury classification score more than 4, and patient having traumatic vertebral fracture. Patients with pathological fracture and metabolic bone disease and thoracolumbar injury classification score less than 4 was restricted out of the study. Coming on to the operative procedure, we used our posterior standard approach, centering the involved spinal unit in 1 vertebral level above and 1 vertebral level below. Superficial dissection was done, then deep dissection was carried out. We cut the spinous process and erased the paraspinal muscle till the facet and the memory process were exposed. The intersection method was used for making an entry into the pedicle using a K-wire, and then probing was done on all the walls to see the intactness. Later on, the tapping was done, and then the pedicle screw was inserted under the CM guidance. The indirect decompression was done by distraction of the pedicle and placing the contoured rod over the pedicle and tightening the lock nuts. The direct decompression was done by laminectomy of the fractured vertebra using rongers of different sizes and until the ligament flame was exposed. The wound was closed in layers after achieving hemostasis and thorough wash. Then later on, the sterile dressing was applied at the end. Post-operatively, patient was given IV antibiotics for 5 days. Wound was inspected on 3rd, 7th, and 12th day. Suture were removed on 12th day, and rehabilitation and physiotherapy was started from very next day of the surgery. Patient were followed up in OPD on regular basis up till 6 months. The case I've illustrated over here is a 52-year male, traumatic paraplegia with involved sensory and bladder ball with radiological evidence of fracture L1 vertebra. This is the ASIA score of the patient. The pre-op ASIA and this motor subscore of the patient is 145 by 224 and 50 by 100. As we can see, there is a significant improvement in the sensory and the motor subscore at 6-month follow-up. It is 162 by 224 and 64 by 100. This is the pre-op X-ray of the patient showing L1 vertebral fracture. The intra-op image showing the 4 pedicle screw along with connecting rods and the laminectomy has been done. Post-op X-ray of the patient. Pre and the post-op vertebral height of the patient. We have restored the height of the patient. Initially, it was 10 mm in pre-op, and post-operatively, it was 22 mm. The pre-op anterior wedge angle was 26.1 degree, and it was improved to 9.5, a significant. Pre and post-operative Cobb's angle was initially 22.7, and post-operatively it was 10.4. The observation that I made during my study was the total 24 patients were included in my study, 16 male and 8 females. The mean age of the patient was 35.58 years. The most common mode of injury was fall from height, including 70.8%, rest were RTA. The most common level of vertebral fracture was L1. After that, it was T12 and L2, and lastly T11 vertebral fracture. The most common associated injury was calcaneus fracture, though isolated spine injury was most common, but associated injury was most common was calcaneus fracture. Now, coming on to the main Asia sensory subscore in pre and post-operative patient, we had 147.25 in pre-op mean, and post-op mean was 160.83, which is quite significant. While Asia motor subscore pre-operatively was 52.92 and post-operatively it was 64, which is also significant. The same was seen with vertebral height, anterior wedge angle, and Cobb's angle. We can see a significant improvement with vertebral height 14.8 going to 21, anterior wedge angle from 19.7 to 11.9, and Cobb's angle from 20.96 to 11.92. During the study, I found a correlation. That is a negative correlation between a Dennis pain scale, a pain scale used by me at 6-month follow-up, was seeing a dorsolumbar pain, and vertebral height. While there was no correlation between anterior wedge angle and Cobb's angle, as we can see, p-value is more than 0.05. There was a correlation, a positive correlation between the functional recovery score and vertebral height, while a negative correlation was seen between anterior wedge angle, Cobb's angle, and functional recovery score. Coming on to a discussion, there was a significant improvement in both post-operative and Asia sensory and motor subscore when compared to pre-operative score. A study of Mohammed Mustafa et al. Reported improvement of Asia grade by 1 grade in 6 of the 8 patients who had neurological affection. This is comparable and significant to my study. Vertebral height, anterior wedge angle, and Cobb's angle improved significantly in my study by 30%, 37.1%, and 40% respectively. VG Huang et al., another study, reported an improvement of 38% in vertebral height and 48% in anterior wedge angle, which is also significant to my study. Strong correlation between the functional recovery score and anatomical reduction based on anterior wedge angle, vertebral height, and Cobb's angle. With increase in vertebral height, the functional recovery score improved, while increase in Cobb's angle and in anterior wedge angle led to decrease in functional recovery score. There was a strong inverse correlation between vertebral height and pain perception. As I told earlier, patients with vertebral height restored in post-op had less pain in dorsolumbar region on 6-month follow-up, but no correlation was found between pain and anterior wedge angle or Cobb's angle. A study of Osmar Amanzi et al. Concluded a weak positive relation between anterior wedge angle and pain. Concluding my study, laminectomy with pedicle screw fixation is an excellent option for patients with thoracolumbar fracture. It not only decompresses the spine but also provides stability with minimal manageable complication. Secondly, fixation leads to restoration of the anatomy of the spine, which directly impacts the neurological recovery, functional recovery, and the post-op lumbar pain. These are the references.
Thank you, Dipankar. Dr. Mayank, start sharing your screen. Chairperson, please. Your
Dr. Dipanshu.
Yes, sir.
Are you using steroids immediately after surgery?
Sir, no, sir. We are not using steroid after the surgery.
In all patients?
Yes, sir. We just give antibiotics and analgesics to the patients.
Any particular reason for not using steroid?
No, sir. There's no particular reason for it. Initially, when the patient came to emergency and if he was within 24 hours, he came to us. We used steroid in that patient during every maintenance dose, but post-operatively, we didn't use any steroid.
Dr. Mayank, start sharing the screen.
Okay.
Dr. Dipanshu, you told that you have used the Asian system for neurological scoring.
Yes,
so, in that system, specifically, the dermatomes and myotomes are be particularly labeled with a systemic examination. So, have you done it properly in your, because we can't see it actually when you're presenting the case?
Yes, sir. Yes, sir. I have scored patient pre-operatively and post-operatively both. Firstly, in pre-operative, when the patient came in emergency, both for sensory and motor, I've done the scoring and calculated it. The total score I have depicted in my study, sir. The mean scoring as I have shown, sir.
Fine. That, because that is very important.
Yes, sir.
Because without it, your publication will not be going to be more authentic, actually.
Yes, sir.
Right?
Yes, sir.
Yeah,
I'm
thank you.
having the
Nice to-
scoring and of all the patients that I've concluded. Yes, sir.
Perfect. Thank you.
Thank you, sir. Thank you, sir.
Dr. Mayank, are you there? If you're there, please start your presentation. Dr. Mayank Kesharwani. Dr. Mayank, please unmute yourself. Dr. Mayank.
Yes, sir. Yes, sir. Yes,
Please, yes, start.
So I would. My topics, it is to study the functional outcome with various radiological variations in comminuted fracture, distal and radius treated by different methods. A prospective study.
Dr. Mayank, please make it full screen.
Yes, sir. Yes, sir. One second. Introduction. Distal radius fractures are among the most common fractures of the upper extremity with bimodal type of age distribution. Factors like fracture type, age, delay in surgery play an important role in determining the management of the patient. Anatomical reduction following distal radius fracture is important, particularly in the intra-articular fractures and in young and high work threshold population. The purpose of this study was to evaluate the functional outcome in distal radius fractures patients managed through volar LCP, external fixator, KY fixation, and through conservative methods. Aims and objectives: to evaluate the functional outcome in comminuted fractures of distal radius treated by various modalities, a review of literature of fracture distal and radius, to study various complications in follow-up patients of comminuted fracture distal radius treated through various modalities. Materials and methods: patients with distal radius fractures attending the casualty in OPD and those who are admitted indoors of SPPP hospital associated with LRM Medical College, Meerut, were taken for study. This was a prospective study for 1.5 years. Patients were selected as per a definite inclusion and exclusion criteria. The inclusion criteria was skeletally mature individuals. I've taken intra-articular type of fractures, AO type B and type C, and closed fractures. The exclusion criteria was age less than 18 years, extra-articular fractures, undisplaced fractures, all open fractures, other associated ipsilateral fractures of the upper limb, neglected fractures more than 4 weeks, and severe comorbidities. And history of previous risk pathologies, fracture with congenital or other forearm anomalies, and patients who were lost to follow-up. Thorough clinical examination of patient was done. Routine investigations were sent, and all patients were radiologically evaluated through AP and lateral radiographs. Post-injury volar tilt, radial inclination, radial height were measured. The selection criteria, whether to treat operatively or non-operatively, dependent upon the type of fracture, duration since injury, and other factors as described by the LaFontaine criteria, which says that in case of dorsal angulation, which is more than 20 degree, dorsal metaphyseal combination greater than 50 degree, initial displacement of greater than 1 centimeter, initial radial shortening of 5 millimeter, greater than 5 millimeter, associated ulnar fracture, and in case of severe osteoporosis, patients with 3 or more factors have high chance of loss of reduction and hence were considered for operative intervention. Type of intervention, non-operative, I had close reduction with above elbow POP cast application. And in case of operative, it was external fixator, close reduction with KY fixation, and volar LCP plate. In case of platings, it was modified Henry's approach was taken. And in case of post-op management, patient was given IV antibiotic post-operatively for 5 days. Wound was inspected on day 3, 7, and 11th post-op day. Sutures were removed on 11th post-op day. Rehabilitation and physiotherapy started from Wednesday of surgery. And regular pin track dressing was done in case of KY fixation and external fixator application. Patient followed up in OPD on regular basis till 6 months. And analysis and result after the treatment, all the patients were followed up for clinical and radiological examinations periodically. Patients were followed up at 1.5 months, 3 months, 6 months, and 1.5 year with end point of follow-up being 6 months. Radiological assessment was done by measuring volar tilt, radial inclination, radial height. Functional assessment was done by modified Mayo's risk scores Anatomical assessment was done by Sarmento modification of Lindstrom's criteria for anatomical end result. Case illustration, Mangal Sen patient, it was AO type B, and Mayor score was 85. This is a pre-op X-rays, the pre-op parameters. Post-op X-ray, intra-op pictures, 3 months follow-up, and 6 months follow-up. I try to get patient do pronation, supination, and palmar flexion and dorsiflexion to assist. And the other one is this patient is also AO type B. It was managed by external fixator application. Mayor score was 75 in this patient. The fourth follow-up visit after 6 months. Observations, total of 51 patients, 26 male and 25 females were studied. The commonest age group of patient was 21-40 years, with mean age being 44 years. The most common mode of trauma was fall on outstretched hand. Majority of patients had left-sided injury, with maximum being patient being managed conservatively. It was observed that the functional outcome in patients operated managed within 7 days of trauma with follow-up period greater than 6 months had much favorable outcomes as compared to those with delayed managements and with shorter follow-up duration, thus establishing a positive correlation between early management and longer follow-up duration with resultant functional outcome. Majority of patients treated through operative methods had excellent and good results in terms of post-operative anatomical parameters like residual deformity and residual dorsality, and as calculated through Sarmento's modification of Lindstrom anatomical criteria. Whereas in case of patients managed conservatively, majority of patients had fair to poor results. Similarly, functional outcome as calculated through Mayo's risk score in patients managed operatively were excellent in 53% of patients, in contrast to 8% in conservatively managed patients. Relation between the delay in management with Mayo's score, it was seen that patients in which there is delay of management for more than, in case of less than 7 days, the Mayo score was more than 85 in 35% of the patients. Whereas the patient in which there was delay, that is, patient was managed after 7 days, the Mayo score was greater than 85 in only 16% patients. The functional outcome in patients operating, as I mentioned, sir, the relation between the delay in management and functional outcome is statistically significant. And then duration of follow-up and Mayo score, longer it has been proved that longer the follow-up, the functional outcome has come better. The functional outcome here is noted by the Mayo score. In case of follow-up greater than 6 months, it is 43%. Patients had a better Mayo score. And Sarmento's modification of anatomical criteria in patients managed operatively, majority had excellent results, whereas in case of conservatively managed patients, majority had poor fair to poor results. And the relation between anatomical outcome in terms of residual deformity in operative as well as conservative managed group of patients was found to be statistically significant. I mentioned. Now the comparison of Mayo, yes sir. Comparison of
conclude, man.
Yes sir. Comparison of Mayo score in conservative and operative. In operative group, Mayo score was excellent in 53% of patients and good in 37%, whereas in conservative group it was excellent in 8% and good in only 15%. And functional outcomes in terms of range of movement. Discussion in case of comparison of range of movement in when I've compared my study to a study by Jupiter et al. and Kobe et al. Sir, the results are comparable and to my study of operative group. And similarly, in case of comparison of range of movements like palmar flexion, dorsiflexion, supination, pronation, the results of my study in operative group are comparable to Orbe et al. and Kobe et al. And I conclude by saying that VOLA LCP should be the management of choice in intra-articular fractures, especially in comminuted fractures with distal displaced fragments of distal radius, and also in younger population with high work threshold, external fixator and KY pinning would come next and should be considered for partial intra-articular fractures, and also in neglected fractures for providing satisfactory result with minimum complications. Conservative management using close reduction with cast application have given fair to poor results in intra-articular fractures and should be considered for old osteoporotic patients or patients which lack surgical fitness. Thank you, sir.
Ma'am, Dr. Suresh Chaurasia, please start sharing your screen.
Dr. Mayank, nice presentation, extensive work you have showed with the scoring system. But we want to ask you a few things. Like you have mentioned that we have seen that in one of your cases, the fixator was given on one side. So it is always better if you're going for a just fixator in the comminuted cases for both the side fixator system, not on the one side. So maybe because the most common complication in all these conditions is definitely malunion, even after placing a fixator also, and that is more increased when it is a one-sided fixator. First thing. Secondly, you have mentioned that in the conservative management, you want to give a long cast, but you should mention it for how duration. Is in all the lower end fracture, you give a long cast, above elbow cast?
Yes, sir.
I think
for 4 to 6 weeks, sir.
4 to 6 weeks.
In case of, yes, sir.
You have to mention in which case, in which condition, because there are some
extra-articular fractures. We prefer conservative management through cast, and actually my study was about AO type B and type C, which are partial intra-articular and complete intra-articular fractures. And the patients which have been managed conservatively in this are patients I've mentioned who lacked surgical fitness or were old patients in which we couldn't operate because according to LaFontaine criteria, they should have been operated as they are intra-articular, and in case of dorsal comminution greater than 50%, if the fracture is meeting these criteria, it should have been. Yes, sir.
Right. And the most important thing I want to ask is, what is the most common shoulder hand syndrome which has been seen in your series or not? Because it has not been mentioned here. This is a very common problem with whether you are managing it with a open reduction or with a closed reduction. You have not mentioned at all about any of the shoulder hand syndrome presentations.
Yes, sir.
Is it was there in any cases, despite in the young patient can also be seen? Actually, it's not always that it is going to be there in the old age group.
Yes, sir. So, in maximum patient, there were complications of residual deformity and sir, finger stiffness. Yes, sir.
Fine.
Thank you, sir.
Right. Thank you.
Dr. Mayank, can I ask a question?
Yes, sir. Yes, sir. Good evening,
Dr.
sir.
Mayank, I am Santosh.
Good evening, sir. Good evening, sir.
See, you have 4 groups, 3 operative and 1 conservative group, and 51 cases in your study.
Yes, sir.
But you have not shown anywhere how much cases in which group.
Sir, there were 13 cases in conservative group and 38 cases in operative group. In operative group also, there were 17 cases in external fixator and K-wire and 21 cases in a case of open reduction internal fixation with Goel LCP plating, sir.
Okay. And
Thank you, Dr. Mayank. Please.
An external fixator?
So we already running very late.
Pardon, sir.
Sir, can we proceed to the next speaker, sir?
Sure, sir. Sure, sir.
Dr. Suresh, start your presentation.
Thank you, sir. Thank you, sir. Thank you so much, sir.
Thank you, sir.
I am audible?
Yeah, you're audible, Suresh.
Very good evening, my respected teachers, my seniors. My topic is functional outcome of fractures of clavicle treated by superior plate placement. Introduction: it is a common fracture that account approx 2.6% to 5% of all fracture in adult. Approximately 80% of the fracture occur in middle third of the bone. Approximately 70% of mid-third fracture in adult are completely displaced. There's a classification called Robinson classification. In this, there is a type 1A, 1B, 1A, 1B for medial 1/3. Type 1A1 is extra-articular, and type 1A2 is intra-articular. Type 1B1 is extra-articular, and type 1B2 is intra-articular. That is the difference in this. B is for displaced fracture and A is for undisplaced fracture. Similarly, 2A and 2B, 2A for undisplaced and 2B for displaced fracture. 2A1 is undisplaced, 2A2 is angulated, 2B1 is displaced, and 2B2 is a comminuted fracture. Similarly, for lateral, 3A displaced and for undisplaced, 3A is for undisplaced and 3B is for displaced. And similarly, there is a 3A1 and 3A2, and similarly 3B1 and 3B2. Material and method. This prospective study has been performed at Jawaharlal Nehru Institute Center, July August to 2022, May 2021. A case series of 30 patients has been included in this study. There is certain inclusion criteria and exclusion criteria. In inclusion criteria, age greater than 18 years, acute injury, mid-step fracture, Robinson 2A and 2B, and normal shoulder function before injury. This is our inclusion criteria. In exclusion criteria, pathological fracture, more than 2-week-old injury, open fracture, and shoulder joint arthritis. This is my exclusion criteria. Outcome measure. Primary outcome measure of fracture union confirmed by X-ray. Functional outcome measured by constant and Morley score. Follow-up 4-week, 8-week, and 12-week. This is intraoperative picture showing patient in each position and some instrument. This is pre-op X-ray. There is a post-op access also. Post-op follow-up at 12-week, showing superior plate placement. This is clinical picture of my patient. There is an abduction of 90 degree, of extension 90 degree. This is a picture of 12-week follow-up. Result. In our study, 25 patient fracture united on an average 10 weeks, and five patient united 15 weeks. 3 patient, there are some complications. 3 patient had hypertrophic scar and 2 patient had plate prominence. Functional outcome assessed by constant modulus in our study, 23 patient has excellent outcome and 7 patient have good outcome. Conclusion. In patient with displaced mid-step clerical fracture, open retraction and plate placement, superior plate placement give good clinical outcome. However, there is a few complication has been noted. There are some certain limitation, less sample size and less duration of follow-up. Thank you.
Okay, Suresh, why you want to operate these cases? What are the difference you find with the conservative treatment? Why you need the fixation for this one?
Yes, sir. Actually, basically, there is certain indication if there is shortening more than 2 centimeters, and there is a displaced fracture of with skin tenting, fracture associated with neurovascular injury, if there is open fracture of the clavicle, a floating shoulder, or fracture with obvious fracture with clinical deformity, obvious clinical deformities, fracture associated with other trauma.
Yes, you are right. In these cases, you should operate, but no case has been related to these indications. You have excluded the open fractures. You have excluded the other shoulder, and no case have a.
Yes, sir. Basically, I'm speaking all. I'm speaking the criteria where we do open and plate fixation.
That's why I'm asking you, in your cases, why you select the operative cases if there is no indication for that one.
Sir, there is in my cases. Wait, I'll show the slide. First of all, age criteria is more than 80, acute injury. Robinson 2A, 2B, sir. Itself.
Suresh,
yes, sir.
You can answer your question, but don't go back to slides. No?
Okay,
you
sir.
Can answer, sir. Please don't try to prove yourself. You can answer.
Yes, sir. Shortening more than 2 centimeters, sir, basically. And age is one of the most important factor for me.
Okay. Fine. Great. Thank you.
Thank you, Dr. Suresh.
Thank you, sir. Thank you.
Any
sir.
more questions?
Can I comment something?
Sure, sir.
See, basically, this total E-Pgcon is for the research methodology, whether the PG students are following the research methodology or not what they are doing or what they have done.
Actually,
basically, we assess the methodology. Like in the previous one, when I was asking, he said that he having exclusion criteria. What is the exclusion criteria? The patient, those who lost to follow up. we have to see these things. When there is a loss to follow up, it is not the exclusion criteria. It is the failure of that group according to intention to clinical analysis.
Yes, you are right.
Do all these things and tell the student about these things, not the why you have done this, what is this done. What I am feeling by seeing all the presentation, we should focus more on the how the student had done the research methodology right or not, because in that he is not shown any number of the patient in different group, although he is saying I am having 4 group. How you know when you are not saying? So I think we should assess these all things. And
Actually, research, the most research methodology is very important, and most of the time we are lacking in our country with the right approach, and that is why our papers are not being reaching to a level where it should have reached, despite we have a good clinical material. So please focus on research methodology portion only.
Yeah, that's why Professor Santosh Kumar has pointed out these things. Why the E-Pgcon is there? What is the aim of this? It is quite correct. The aim is the how to research work to be done and how to present them. Yes, it
Thank
should
you, Chairperson, sir.
Yeah.
Any more comment?
Thank you, Dr. Ashwani Sadana.
Thank you, sir.
Thank you so much.
We'll
Thank you
conclude
so
now.
much. Thank you so
Thank
much.
you. It's
Thank
been a
you so
nice
much.
day.
Thank you so much.
Yeah.
Thank you. Bye bye.
Thank you. Thank you, everyone.
Bye.
Thank you.
Bye.
Thank you.
Bye.